necessary. Medications that are delivered to the home, whether by vehicle or now via drone deliveries are coming. The same thing with meals. Meals can get delivered and the like. Very different scenarios, and the patient is at home. And I don't know about you, but I would rather be at home in my own, even if it's a hospital bed, if it's not my own bed. But I would be much more comfortable at home. We know people heal faster mentally and the like. But there's a lot of challenges with this too. It's a good system, but it's not perfect. So lots of opportunity to harm the patient in this scenario. You now have multiple caregivers that are remoting in but may not be seeing each other or talking to each other. In a hospital, you tend to round together. Hopefully the EHR negates some of that. Do you have access to the right equipment? Is it properly calibrated? Because you can no longer swap it into the hospital and have your technicians adjust it on the fly. Again, you may not have the diagnostic equipment that you need. How do you handle the medication management in the home? And who's administering the medications? You don't have as many hands-on. There's not the nurse that's there around on a regular basis if it's a skilled nursing facility or the like. What are your setups for an emergency? What happens? You can deal with it, but you have to plan for it. And is the patient and the family truly engaged in this process where, you go to if you're in the hospital or another type of facility, there's someone around you all the time to sort of guide that. And then, I don't know about, your family, but as my parents said, my parents are in their 80s, I'm not sure how familiar they are with some of the newer technologies and can they manage it. They call my son for help. And so you have to be prepared for that as well. And then what happens when the equipment fails? Wi-Fi goes out if it's a remote sensor. What are the backup plans? And then you still have the security and patient privacy issues, data issues. So these are all potential areas of harm in this scenario. That's my job as JCI is to help hospitals and organizations and prepare for this and prevent these scenarios or deal with these scenarios before they ever arise. For the providers, there's also issues, both good and bad. There's challenges, right? Can you ensure consistent outcomes in this type of environment? Care has the opportunity to be fragmented because of the different providers and not everyone in the same space. There are safety risks in the virtual environment, and it's a different skill set. Delivering care remotely as a physician is different than doing it in person. Doesn't mean you can't do it, but it does require training. COVID forced physicians into doing it right off the bat. And I will tell you, I think younger physicians adapted much quicker than older physicians. You're used to spending half your time on your phone and video chatting and everything else, so it's second nature. For someone of my vintage, it's not necessarily the case. And so there's a training and skills piece that we have to, and then the reliability technology. The flip side is, this is patient-centered care at its finest. Right? In the home, personalized, meeting the needs of the patient and the family. Assuming you all want your family during some of this, but it actually increases accessibility to services and like if you're not trying to, get in a car, particularly in this city, and trying to, go someplace to visit the physician or visit a different facility, it's all coming to you. You can manage populations this way and great opportunity to leverage the data coming back from all this remote sensoring and the like. And there are some cost efficiencies and there are also some advantages we don't think about. One of the, in my mind, is because one of the things we focus on in Joint Commission a lot is infection control. And on one hand, you think, how do I keep my home clean enough to take care of a sick patient? On the other hand, you don't have very difficult to treat organisms. So it is kind of an interesting piece that we don't think about. So I've sort of talked about the benefits, I've talked about the challenges, there's some goodness and there's some things we really need to do to make sure we deliver safe care. So what are some things we can do about it? And that's where Joint Commission comes in. So first of all, what do we mean when we talk about quality? Really zero harm in daily work. And that's zero harm for the patients, the healthcare workers, and really their families. So that's, good outcomes safely. And then how do you get there? Leadership commitment, culture of safety, and really ongoing quality improvement. Those are the foundational elements to really achieve zero patient harm and high reliability. But it applies really all the time in a hospital, and it applies to this new hospital. As we look at this, one of the things you have to keep in mind is the ecosystem of who is in this space. We don't, if you work in a hospital, you don't think about it because it's part of your daily ecosystem. You deal with, providers, you deal with the lab, the pharmacy. You try to avoid the regulatory bodies, but they exist and they put a lot of the rules and guidelines in place. Accreditors, whether, in India it's us, it's NABH, among others. You deal with the medical equipment, the platforms, the IT platforms, the telehealth in this area, and understanding that helps. So what I would like to talk about really is there's 5 areas that require careful coordination and attention to ensure the safe care. One is the leadership commitment. I touched that before, but it really does start at the top of the organization, and it filters down. Leadership occurs at all levels, but the very top, really committing to standards, really committing to a culture of safety, ensuring you have resources. It's really hard to provide care without resources. That's one of the jobs of leadership, is to provide the tools necessary for everyone else to do their jobs. Second is the infrastructure and the technology. Do you have protocols? Do you have good policies and procedures in place to standardize your care? Because all of these things we're talking about really requires protocols in place. Again, Wi-Fi goes out, you lose control. You're dealing with a patient in their home who suddenly is codes and goes into a dangerous arrhythmia or stops breathing. What do you do? And there's no healthcare provider. There are ways to deal with it. And in the U.S., make sure you can call dial 911 and the equivalent in India as well. But again, you don't want to have to think about it. You want to know what to do ahead of time. Ensuring you have quality assurance programs in place and compliance. The accreditation, certifications is necessary. Making sure you have data security aligned, because this is all data-driven information, and ongoing continuous improvement so that you're looking at what you're doing and you're constantly adjusting it and improving it. The education and training aspect. I already mentioned before that providing telehealth services is a new skill that we have to be prepared to. We have to train, the various staff that are going out to do this, whether they're doing in-home assessments, the like. Are the providers and the nurses, are they trained, are they competent, and are we assuring that they remain that way? In terms of the home, the patients and their families, are we educating the families as well? Right? What do they do if something goes wrong? What are their role in this? The good news is we want our families involved generally, but we can't take it for granted. And then finally, the patients have rights, as we all know. And we want to ensure those are not infringed upon, that they're enforced, and they understand them. And then involving families is needed in the care. This is really patient-centric care. So you want to ensure that you are covering all these bases as part of this process. This applies, in the hospital as well, in other settings, but it's key in this new healthcare hospital paradigm. So I wouldn't be here talking about it if I didn't think accreditation helps this process. And it does so in a number of ways. Accreditation really helps foster a culture of safety in an institution. And that institution extends outside the walls as well. Really, I talk about accreditation, it's a fundamental change in how a hospital operates. It gives the organization tools from a quality improvement standpoint, but it really helps instill a culture of safety and a new way of looking at how they deliver care. I like to think an appropriate way, and that's not unique, and that's what accreditation in general does. It helps leadership. You don't get accredited if your leadership isn't interested in the process in the first place. So it really fosters that ongoing leadership commitment. There's a lot of standardization that occurs during accreditation based on current medical evidence. It drives patient-centric operational excellence, because we're all focused on the patient and we continue to drive that focus. It builds, as part of this process, it drives ongoing continuous improvement. Different areas and different hospitals, but it really fosters that process, and it's built into ongoing accreditation. And it allows a third party to come in and take a look and say, yeah, you're doing this really well, or In some areas, you could do a little better in your medication management or your medication administration or your infection control. It's not about you're doing it wrong, but how do we help you do it better? And so, as you can see, these tie into a number of the factors that I brought up before. I'd like to highlight it a little bit more. I'm going to touch on our telehealth standards as an example. The hospital without, at home really is a combination of other standards, which I'll talk about. But we divide our standards really into two major categories. There's patient-centric, and there's really healthcare organization type of thing. From the centered standard, we talk about patient safety goals, access to telehealth standards, patient rights and responsibilities, medication management. These are tied to the patient. Other things are really tied to how a hospital operates, such as the governance and strategy, and data structures and things like that. You can think of one as infrastructure, one as patient-centric. These are some examples within those categories. On the patient-centered, what does the registration and intake processes look like? How do you maintain continuity of care and the patient history? How do providers know what occurred outside the hospital during these visits? How do you handle emergency services? Seeing this as an example. And lastly, accreditation. I used telehealth as an example. These are all the different programs that Joint Commission, provides. But I want to, use it as another example. Hospital Without Walls is something new, and it's being talked about. It's not my term, but I love it. But if I was to suddenly make up and to devise an accreditation program for this type of service component, so now you're mixing and matching from different categories, just like we're doing everything else in terms of moving the technology, moving the care. Well, we're doing the same thing with accreditation. I'm not there yet. I'm waiting again to see how the uptake is, but we're obviously going to move in this direction as well, because you all are doing some great things from a care and technology standpoint. I need to be prepared as an organization to support that, so that you can do it safely. So just in summary, the world is changing. It's changing quickly from a technology standpoint, from a care standpoint, and it's driving the change, how we are going to deliver care. I think virtual care is here to stay. COVID demonstrated that, but it's just going to accelerate in how we're doing it. It's going to move away from a simple face-to-face consultation, skin rash, or it's very popular for mental health in the United States for a lot of different reasons. But it's going to expand, and as we have more virtual reality tools, it's going to expand even further. And then ultimately, accreditation is a foundational element for quality and patient safety in any setting, and it applies into this as well. So with that, are we going to do questions at the end, or at the end? Okay, great. Thank you very much for your attention, and hope to talk to you. Over here, so I can see the slides.
Any questions? Should we take a question on that?
At the end.
Thank you so much, Dr. Jones. It was a wonderful summary of hospital without wall, and let us hope that concept advances further to the best of effectiveness. The next topic of our speaker is from Dr. Aarti Thapliyal. She is an industry and innovation head, health and public services, Accenture. She is a health industry expert and helped multiple clients across the globe within the health insurance, hospital, retail, pharmacy, and health network. She is a dentist by qualification, and she has a master's from London School of Economics in Innovation and Entrepreneurship, and she has got executive degree in driving digital strategies from the Harvard Business School. She truly believes digital health strategy can address access and deliver the whole person care. She is going to discuss on the topic innovation cycle. Let us understand. Thank you, Dr. Arti. You want to, please?
I think I'm, as Dr. Joe said, pretty loud, but the mic would help. Do we have a clicker as well? Like, yes. This one? Finally, we have my presentation up. I think we talk about big things in healthcare like space tech and whatnot in current times, but at times there are smaller technical glitches that matter the most, and that's where I think Dr. Joel emphasized enough on patient safety. It's also about, paying attention to details in the care delivery cycle. So thank you everyone for being here. I'm Dr. Arti Thapriyal, and what I will do now is give you a perspective of why do we think healthcare delivery is important, and what are some of the important components that we need to keep in mind, and also look at how technology can transform the way we are delivering healthcare today in terms of improving access, including home care, improve experience, personalized experience for patients, and at the end, there's no care which is good without better outcomes. So how do we transform outcomes? So a quick glimpse on, some of the key pressures or challenges that we see in healthcare system. A lot of my experiences from the US healthcare system, because from Accenture standpoint, majority of our clientele lies in North America and in APAC and Europe region as well. So I think what Dr. Joel has already spoken, you will see a little bit of reflection when I talk about some of the challenges and trends that we are trying to beat through technology. So as you know that there's a huge shortage of clinicians, trained physicians across the globe. WHO has been saying year on year that there is like 33%, 50% shortage of clinicians across the globe, and that is leading for us to think about how do we bridge that skill gap in terms of democratizing technology to kind of come up with innovations that can help physicians to deliver better care or bridge that skill gap. At the same time, access is very important. So how do we again leverage simple technologies? I think my screen is gone. There's a couple of things happening here. And we also see at the same time the baby boomer population increasing, right? There is a huge demographic shift that is happening across the globe. There are social determinants of health which are becoming more and more important. So gone are the days, when you had somebody, I think in the morning, spoke about one shoe size doesn't fit all. So it's the same. We need to keep in mind not just the clinical needs of the patient, but the non-clinical needs as well, which come from social determinants of health, which is basically about your cultural background, ethnic background, your genetic makeup, your nutrition preferences which are relevant to you in your geography, right? So if there are certain food preferences which Indians are used to of, then you can't expect them to change that drastically to kind of meet a certain nutrition requirement. It's a very simple example. So how do we combat the skill shortage? At the same time, how do we make sure that the increasing healthcare need which we have because of the baby boomer population, which have special needs, including the home care need, are also met, and we can bridge the gap with technology. Rising consumer expectation is we would have heard of players like MD Live, Teladoc, which have seen great growth in COVID times, right? Exponential growth during COVID times because virtual care became the new normal, which otherwise wasn't normal until COVID, right? And more than that, now we are going towards hybrid care model, not essentially purely virtual or purely brick and mortar kind of setups that are delivering care, but more of a hybrid care that can be consumed at very innovative care sites. Retail pharmacies are a classic example. If you look at CVS Health or Walmart or Walgreens, they now have urgent care clinics or primary care clinics. So it's a footfall of the customer that you have in the retail pharmacy that you can tap onto, right? And another alternative for you to kind of get a primary care consultancy very quickly as you're in the retail pharmacy. So those are the innovative care models that we see are coming up. And also phygital experience, which means as I walk in from a physical hospital and get into a phone with a physician through a telehealth platform, that experience has to be intact. It's very, very important to kind of have a long-term success in virtual care market now. So gone are the days, when you had a simple 2D telehealth kind of a solution that works for patient. Now patients are asking for more superior experience. They're asking for, experiences, that can provide them an end-to-end view of their clinical care, which is very well integrated in the healthcare ecosystem, right? So there's a hospital, there is a pharmacy, there are the lab partners that are out there, GetLab, BlackQuest, all those big players in the US market, and then you have insurance, which is one of our largest revenue market in the US. You have insurers out there, you have allied or auxiliary healthcare services. So all that has to work well in conjunction to give you that superior healthcare experience, which is truly, truly omni-channel. Otherwise, you're struggling with 20 apps and trying to get that experience which doesn't work, right? So starting from your pre-visit processes, starting from your registration, scheduling, to your visit processes, which is like seeing a patient, getting the consultation done, to post-visit, which also, includes your billing processes, your post-visit summaries that come to you as a patient, and prescriptions and labs, all the tangents that come out of your complete experience has to be also looked upon. Cost of care, again, is a common phenomena. Everybody spoke about it. But what's more important to think is, how do we reduce this cost of care? And as a provider in the market, or a payer in the market, or a public health player, or a middle player like care management organizations that we have in the market, how do you reduce cost of care for your customer, be it the patient from a hospital standpoint, and be it the member from insurance standpoint, right? So particularly talking about insurance, like a lot of us have been talking about a lot of hospital work, but we also serve a lot of leading healthcare insurance player in the market across the globe, and they are struggling with high cost around managing their administrative processes, adjudicating claims, the huge claims that come from hospitals. How do they regulate the cost of care which could happen because of fraud, waste, and abuse, because of prescribing habits which are not medically necessary. So there's a huge healthcare management component to the insurance business as well, which is very, very important to be kept in mind to have a complete conversation on this topic. So how do insurance also make sure that the quality of care, patient safety, zero abuse to the patient in terms of unnecessary services is also checked. And lastly, accelerated technology. I think all the eminent speakers so far have spoken about how technology itself is a driver to this change and is accelerating this change like never before. And there is no way out but to adapt to this change, right? And I'm sure AI, data analytics have been spoken. Now we have generative AI, where we have large language models trying to help hospitals in doing documentation which otherwise took hours and hours on a daily basis, right? So think about if there are practitioners in the room, what kind of documentation that goes into on a daily basis when you see your patients. You are supposed to document your visit notes in certain formats. So and it also has a quality implication. The document better be good, otherwise you can be quoted for that. So how do you make sure that that is of high quality, and at the same time you're not spending too much of time doing that for millions of OPDs that a patient might have and providers might have. And that's where there's generative AI application as well, which is trying to help hospitals and doctors to get summarization of their visit notes, automatically put together with fine prompt engineering to kind of just create a very nice rough draft for the patient provider, which can be reviewed quickly by the physician and approved. So they are saving time in terms of rather than spending 30 minutes, 45 minutes to do a 60-minute visit documentation that you had with the patient, you probably are spending a few minutes, right? So and of course in technology you can talk about metaverse. I'm sure a lot of you already have heard, but we don't see a very large scale application of metaverse, AR, VR as such in the healthcare because of many constraints around the need of a device. Though AR, VR headsets are becoming cheaper and cheaper. Now you can get a nice VR headset for probably $100 and $200 as well, but that was not the case earlier, right? You have wireless. Now Apple has launched the latest one, and there are cheaper ones in the market. So how do you make sure that that technology is also kind of explored for the reasons of providing care at scale remotely? So some of the experimentation that we have done in Accenture's Innovation Lab is, I think in the morning session, Dr. Reddy spoke about how do we leverage technology to scale the screening of eye issues. For example, cataract, glaucoma. These are some of the these are probably the top 2 killers of the eye across the globe, right? Which cause the maximum blindness. So how do you make sure that all the huge data of images that the eye hospitals have, how can I make sure that I'm able to use that with predictive analytics and being able to tell the physician that this is the possibility that this patient might have a glaucoma and so on and so forth. And diabetic retinopathy is another area which is again increasing in patients with diabetes, and many a times our diabetologists are not equipped with the right skills of an ophthalmologist, right? So they are focusing on the diabetes of the patient, but imagine if they had a quick solution where they could take an image from a camera which has a fundus lens and tell you that you may have diabetic retinopathy as well, which is one of the apathies that come with the diabetes disease, right? So how do you smartly equip our physicians to be able to proactively manage some of these conditions at scale and screen proactively? There are VR solutions today in the market that can screen for glaucoma. You have standard automated perimetry, frequency doubling perimetry tests that can be curated in VR headsets, that can be even taken by patients themselves because glaucoma requires very, very periodic visits to hospitals, and you have heavy devices like Humphreys, Heidelbergs that need to be only kept in a physician's office. They're very expensive, importable, very bulky, not mobile. So you need to pay frequent visits to the hospital, screen yourself, and make sure you're able to detect glaucoma for high-risk patients on time. So these are some of the areas where we see technology can play a huge role and turn the experience upside down and revolutionize the way that we deliver healthcare today. So while we see some of these challenges which are becoming an accelerator for thinking about innovating across different tenets of payer, provider, public health workspaces. The payers, the insurers or the providers or any other allied services providers in the healthcare are also rethinking about how to fulfill their key priorities, which for me are how do I improve access, how do I improve experience while the patient is consuming care in the whole care curriculum that I just spoke about, which is end-to-end care, and improving outcomes, right? And in access, we speak about how do we make sure that you are getting access to care anywhere and everywhere. That's where we speak about remote healthcare solutions, telehealth solutions, mobile-based solutions, VR headset-based solutions, and so on and so forth. And how do we make sure that the healthcare is also personalized, so it is very, very unique to your care journey. For example, how do you make sure that a diabetic patient or a hypertensive patient or an Alzheimer's patient gets the right care, which is very well informed by the data as well, right? The data that we have from the historic medical documentation, how do we make sure that is intact? Interoperability also plays a very important role in experience component, because when you have these diverse healthcare providers, right, different hospitals. So imagine if Apollo had to connect to a Fortis or a Max or maybe any hospital in Indian context, for example, right, and if they are onto a different electronic medical record product, it's at times could be very challenging. If you think from a layman's standpoint, right, it's a different tech stack of these two products. So how do you communicate? And if I want to make sure that if I'm a doctor, I'm seeing a patient and the patient has 10 years old healthcare history from his previous encounters in different hospitals, so I want to make sure that I get that data and I'm now making an informed choice by knowing your past health history, what kind of medications work for you, what has been already done for you, and so on and so forth. So it's very, very important to be able to get that consent-driven healthcare information for the patient at any given point in time system. So interoperability is very, very important. Some of the key standards that we work on in interoperability are FHIR, HL7 message syntax, Smart on Fire, and so on and so forth, which are technical standards told by CMS, Center for Medicare and Medicaid Services, and there are regulatory compliance requirements in the US healthcare system that has to be met by hospitals and insurers to be able to seamlessly communicate in the ecosystem without having to worry about data privacy and security requirements. So very, very important to know about these data standards, basically based on the geography that you work in, right? If it's an Indian client, then we would of course look into some of the relations that we might have in the Indian context. Last one I heard, I think there was a Data Privacy and Security Protection Act that's out there, probably still getting discussed, not formally applied in the day-to-day life, but probably when that comes out, we would also have those kind of stringent rules and regulations in our healthcare economy as well. And lastly, outcomes, very, very important, and that's where data is very, very foundational to kind of inform us what kind of treatments, what kind of care practices have worked for the patient in the past, right? So how can we take those data inputs, those insights to provide proactive care? I think a lot of speakers spoke about preventive care. Wellness is the next thing, right? So data would inform us to kind of getting the 360-degree view of the patient's care in the past, and then proactively planning for care before the patient gets into a chronic stage, right? So you can, and there are many products in the market, by the way, in the wellness sector now. If you look at insurance market, so the traditional insurance market, if I talk about the Western countries, used to be typically clinical services. So you had your inpatient, outpatient, and other prescription drugs and whatnot covered as a part of your insurance plan. Now we have wellness services packaged as a product for you. So imagine if I'm a healthy person, do not have a medical history as yet, and I just suffer regular cold, cough, flu, and or some one odd time I go to a physician. So what kind of services are relevant for me, right? So there are fitness services, there are wellness checkups, there are like whatnot. Those kind of things are packaged together to sell a different kind of product to those people as well. And at the same time, we will also keep in mind the personalization of benefits when it comes to health insurance. I think health equity was another very important key theme that was spoken in the early sessions today. And it's very important to make sure there is a price parity and patients are paying for what they get, right? And that's where we talk about value-based care, and I think you touched upon value-based payments, which we say that is the next big thing in the US market as well, and that will become normal as we, as insurers, as hospitals, adapt to this model, and the providers are having more onus to kind of deliver the right care, the right outcomes to the patient, and are paid as per the outcomes of the patient, right? So it's not a fee-for-service kind of a model. It's mostly if you get the right outcomes, you're paid full. There could be penalties if there are adverse events and so on and so forth, and there could be incentives as well if you perform well. So just trying to summarize, I think in provider side, we spoke about, hospitals should be thinking about how do they improve access as demand is increasing, elderly population is increasing, there's a skill shortage, what can we do about that? Clinical workforce shortage, technology disruption is already happening, so we need to kind of, catch up on that. Financial stability and resiliency is again very, very important. So how do we make sure that we also diversify into newer services? Now that's another way of growth for hospitals today, right? And if I talk about some of our hospital clients, I've seen them diversifying into insurance getting diversifying into provider business, insurer becoming a retail pharmacy player, and so on and so forth. So these are very logical, organic, adjacent business opportunities in which we see our clients expanding, right? So either you reduce your costs, keep your costs in check, or you also at the same time you're looking for growth avenues and how do you make revenue as well. So then that's where you can look at newer services or even newer market. In the US market, we particularly serve almost across all the big states around different healthcare domains like Medicaid, Medicare, the commercial and group insurance plan and so on and so forth. So how do you make sure that as a business player you have that strategy ready as well, right? So if I'm a Medicare player, would I want to go deeper into Medicare, maybe get into Medicare Advantage market, which gives a benefit of Part A and Part B as well, and with some amount of premium, you can get better services, right? So that kind of specialization can also be looked at. We have players who are specializing deep into a certain market only. Either they sell group insurance or they are known for Medicaid market or Medicare market. So that's another way of looking at financial stability and resilience for the businesses as they expand. And of course, patient engagement is a given. It has to be there. Whether you are in hospital business or you are in insurance business, the patient engagement has to be intact from end to end. It has to be not just engagement but meaningful engagement by knowing the history of the patient, and then you're reaching out to the patient for specific services. And I think similar challenges also apply more or less to the payers as well. And especially for the payers, just one point to highlight in this presentation is new care models. Now the payers have realized that value-based care is, it's going to be the new normal in the future, and there is more onus on the payers now to kind of serve in this competitive market and make sure they retain their customers, they retain their members, their loyalty, and so on and so forth. And that's why we see very innovative business models coming into the market, something like provider integrators or virtual first models, in which the partnership between payer and provider, that is insurance and hospital, starts very early on, right? So the providers are participating very closely in designing benefits, designing coverage design, what should be covered, what should be the risk, and so on and so forth. Lastly, if the business has to thrive, if the providers and payers have to thrive in the market, they have to look at reinventing themselves, and the reinvention can probably happen across 2 or 3 important tenets. First being, they need to work on strengthening their digital core. If your digital core is strengthened, you can bring in a lot of operational efficiency and new business opportunity. And just to demystify, when I say strengthening digital core, from technology standpoint, I mean adopting platforms, adopting cloud, adopting organization level data strategy, adopting AI strategies, adopting security strategies, and so on and so forth, right? So all these are foundational elements, because cloud gives you expandable, on-demand infrastructure, virtual infrastructure, so that you don't have to invest in expensive technology, and you can as a tenant use cloud platforms, and based on your demand you can increase or decrease your utilization. So that does give an advantage to the players, and I think there are many solutions in the market today for providers and payers which are offering platform as a service kind of a model. So you pay per transaction, right? It's very popular in insurance market as of now, wherein they can just use claims adjudication services, membership and billing services, or enrollment services, and so on and so forth as just module, and need not buy the whole product. I'm going to kill this. So this is just I think I can send these slides over for everyone's read. It's just a depiction of how in the modern world a patient's journey could be, and a lot of those components I've already spoken. How AI can proactively digital twin a patient and beginning what kind of treatment might work for this patient, and I can actually predict your outcomes for the future based on the treatment choice that's made today, right? Let's say if a cardiologist is in the room, so even the valve, specific valve, if they use for a patient for replacement purposes, if that kind of valve will give the right outcome and what kind of longevity and so on and so forth, I think all those outcomes can be predicted to your longitudinal health history, which is all intact, to experience through telehealth components and so on and so forth, while you're also connected to the larger healthcare ecosystem that I spoke about, right? So your data, your history, your 360-degree view, in short, the whole person care vision is kind of is brought to life. Quick examples, predictive health, I think I already emphasized. Home care, I think, is here to stay. Home care is one area which will grow a lot in the coming years, with interoperability becoming a new normal, and it's becoming very easy to kind of real-time stream data from IoT devices, sensors, off-the-shelf monitoring devices, medical-grade monitoring devices, and so on and so forth. There are platform products which are technology agnostic, which can stream data for you at home. Insurers, we spoke about. Outer space, I think space tech is again something that is being discussed in the current times, and we are talking about how can we leverage this data to also improve healthcare, right? So data on your atmosphere, temperature, air quality, etc. can be used. And lastly, the inner space. So outer space is your space tech, and inner space is essentially your nanotechnology, when you have your nanorobots, without the assistance of a provider, operating on you. So imagine you're sitting at home, and even surgeries or some sort of minor procedures can also be done through nanorobotics, so which is very, very cool and very disruptive to imagine. And this is my last slide, and what I'm trying, I would like to leave you with this thought. Irrespective of the healthcare business you are in, if you're a hospital-based provider, insurer, a medical device manufacturer, or an insurer, or a telehealth platform owner, you have to kind of collaborate to provide that 360-degree experience to your patient. You cannot provide that in silo. Interoperability component has to be there, and what you see in the market is just the tip of the iceberg. There is lots to be realized, right? So without collaboration, we cannot realize this healthcare vision that we are talking about, where pharmaceuticals, hospitals, insurers, medtech providers, regulatory agencies, and so on and so forth are kind of interconnected and sharing data to provide the best care possible to the patient, and that's where technology can truly help. So with this, I'll put a stop on my presentation. So thank you so much for listening. Thank you.
Thank you, Dr. Rati, for a wonderful presentation. We have heard about the hospital without walls and innovative options and solution in healthcare. Now, third important topic, we are moving toward the humanizing the healthcare in the digital age, which is a very, very vital and sensible topic to discuss. Speaker, Mr. Sandeep Sharma, who is an Executive Director and founder of VMarsh Healthcare. He is a biotechnologist as well as the management expert from Australia. He works across the globe with health policies, health solutions, consultancy in different countries, and he is an He has an office on multiple places across the globe. He has led the advisory, consulting, transformational strategy and healthcare leadership project in 6 continents. He is also chairman of European Fertility Society for Global Strategy Committee, setting up policies and strategies for IVF tourism, focus between the Europe and MENA regions. He is also a member of Standard Advisory Board of Global Healthcare Accreditation, involved in medical tourism strategies across the globe, and he is passionate about the operational excellence, patient safety, and enhanced patient care experience. Please, Mr. Sharma.
Thank you so much. So I'm going to follow what Joel did. Speak without a mic, speak without technology in my hand. I do have one. But anyways, it's a pleasure to be here. It's always great for us to come back to India and speak here. We're very thankful to Sangeeta and Gaurav for having us here. Thank you so much for the generous introduction. Just to give you a heads up before I move into the topic, we are a specialized advisory firm with 5 offices. That's Chicago, Cairo, Dubai, Mumbai, Kuala Lumpur. And we work across the 6 continents with 34 representatives across Europe and Latin America. And we are focused on 3 fundamental areas. That's business strategy, quality improvement, and transaction advisory. The reason why I chose this topic is because, when we do projects all across the globe, we see a lot of these discussions on integrations, on omni-channels. I think she covered that. We realize that there's a lot of integration, there's a lot of shift from doing things in a humane way to a digital way. So I want us to take a few moments to focus on how the humane factor, the factor of empathy, still has to remain at the center stage of healthcare. And we use technology on the sidelines of it. So I think I'm the only speaker who is speaking against technology slightly, so I hope I survive and I don't get killed by the end of this presentation. But anyways, moving into that, I will start by saying that, if we talk about... there you go. So, if we talk about the digital effect of healthcare, I think I don't have to speak much because my other colleagues and Sangeeta in the morning and the Union Minister covered a lot of those things which is going on globally in digitizing healthcare. So, if I have to just summarize it, of course, digital health itself has disrupted the whole way of doing things in healthcare, right from the provider level, the payer level, but more importantly the regulator, because all the policies, all the SOPs, all the ways of doing things have shifted, as we heard in the morning about PPPs, public-private partnerships. I think today if you do a global statistics on PPPs, the highest number of PPCs are in integration of digital and the manual ways of doing things. So needless to say that all the things technology has done, as an advisory firm, we do a lot of work on medical travel capability building, which means integrating with public-private partnerships, doing a lot of work around satellite clinic setups, doing a lot of work around building center of excellence. So when I talk about it from the medical travel point of view, I think COVID did a lot of bad. It had all its calamatic effects, lives were lost, all those things would happen. But if we look at that small beam of positive light during COVID, it made us realize that healthcare can be made more accessible and more mobile than we thought it ever was. And that's why there's been a shift in medical travel. There's been a shift in doing, as Joel said, taking healthcare to the homes, of people. So we see all those shifts. I think my colleague spoke about omnization, voluntarization of healthcare. We hear a lot of things now, virtual reality coming into play, AI coming into play, as Sangeeta said in the morning. So with all that said, of course, there's been so much of tremendous shift, and I'll give you one example, because as someone said, that wellness is the new talk of town, and we do a lot of work on wellness and rehabilitation. So I happen to have this friend who's based, in Sydney, Australia, and he basically does a lot of geriatrics rehabilitation. Now, he's a good friend. The other day, a month ago, we were talking on Zoom, and we were talking, and he was saying, Sandeep, there's so much that I'm doing now virtually on rehabilitation, which I could not do before, and it's so nice. And he really had me intrigued. And while all that was happening, suddenly his Labrador jumped on the laptop fell, and then 10 minutes later he calls me and says, sorry, my Labrador jumped on the laptop, so I lost connection. Now I'm coming back. So in that moment, I was laughing and I was saying, you see, all these good things are happening with technology, but there is still that natural, humane, or lively factor that needs to remain at the center. So from that point of view, I just want to talk to you about very quickly 2 case studies, because I'm saying all this, but what's my context? We, as a firm, did a mystery shopping exercise in Singapore many years ago, where it's one of the leading hospitals. They have the best of accreditations. They were endorsing robotic surgeries. They had best equipments. If you talk to them, they say, you will not find so many brains in one facility anywhere on the planet. They would probably endorse that, at that point. So we said, okay, all this looks cool, all this looks good. So what we did is we sent one of our consultants, we made her dress up in sportswear. We made her run on a treadmill. And then when she was perspiring, and she was of South African origin, so when she was perspiring, we gave her a backpack and we said, now you go and walk to the reception of the hospital and say that you're a tourist, you have a bad back pain, you don't have any idea what to do, help me. So she actually did that. So once she reached this beautiful facility, robotics, state-of-the-art, best doctors, gold seal, all of those things, at that point when this patient, our consultant, who was, in this case, a tourist, walked to the concierge and said, I have a back pain, I'm not feeling well, I don't have an insurance, I don't know what to do. What do I do? And in that moment, the receptionist was a little bit taken back and said, okay, hold on, just go there and talk to that person. And the face that she made, in that moment made the hospital, think that all the capacity that you've built, all the things that you've done is on one side. But if the simple entry point of a patient is not taken care of, what good is all that? So that's my point. Going back to what I'm saying, technology is a tool. Technology is helping us solve a lot of problems. Technology is helping us find so many new things. But we have to remember, healthcare at the end is all about empathy. So that's one example. I'll give you another example from Dubai, which is where these days I'm based. We have one of the hospitals which, if you go to any of the exhibitions, they have the largest booth. One of the most famous roads in Dubai has a huge billboard of them talking about that, we're now doing orthopedic surgeries through, AI, and we're able to augment all those things and stuff like that. And I had one of my friends, who had just moved to Dubai from Italy. And she was very new, she was fairly new. And she asked me, Sandeep, which hospital do I go? I said, look, all hospitals around are good. Pick the one which is closest to you, and you can build sort of a relationship there. It took her a day and a half just to get on the phone with the right doctor to get the right appointment. And I'm talking about a hospital which is endorsing robotic surgery. So again, my point is that we might make things very complicated or very taken forward with technology, but sometimes we need to also keep things simple and focus on the simplest touch points, which a lot of us ignore. So those are 2 examples. Now, again, as I said, I don't want to be killed, so I'm not saying technology is bad. I'm not saying technology is evil. But all I'm trying to summarize, and as we speak today, I think I can divide the issues into 2 boxes. So there's operational and information issues, and then there's safety issues. So while we're hearing HIS and health information being optimized, which will get optimized, but as we speak today, while we evolve healthcare technology, a patient, if a patient is sick, he or she needs healthcare today. What does that mean? In today's time, we still see that there's always a risk of healthcare information breach. We worked with one of our partner firms which was investigating a fraud, and we found out that the healthcare information from the royal family of Qatar was actually leaked, and it was to be misused. So those things still exist. Those things still happen. If I'm talking about altered data, we've seen so many places. I've myself seen hospitals in South Korea where they have built these beautiful dashboards where as soon as you go, you have all the information that there is on the patient. But what is to say that something in that is not up to date? And let's just say if someone picks that up and starts, treating the patient based on that, where is the actual diagnosis? Which also leads me to the point on the left. Too much reliance on technology is also taking away that learning curve from residents. Think of resident doctors 20 years ago. The challenges that they had, the things that they had to do, it made them more resilient. It made them more, I would use the word street smart. But today, because all those things are managed by technology, you are also sort of limiting your endurance to face new, unique, complicated situations. Of course, as I said, as Joel said, whenever his mom has issues, he calls his son, and he helps him with those things. You also have to think, at the end of the day, when someone in that, a baby boomer or anyone who is not so technologically savvy, in a point of discomfort, are they really ready to sort of use and play with technology then, or are they looking for immediate help? So while we sort of optimize technology, we also have to be ready for healthcare for today. And having said that, on both sides, while these things are being uplifted or moving from sort of a pilot to a more advanced phase, you have to remember that there is a cost on both sides which is going up. Because it's very simple. If a hospital is acquiring a new technology, it's getting integrated, they're paying for it, eventually that line item is going to show up in the bill of the patients. Today, if there's a shift for wellness, the reason is because secondary and tertiary care is insured, wellness is not. Hospitals are finding a way to have the secondary tertiary care covered by insurance, which is limited, which has a price cap, but then use the wellness kind of cash cow stream to then put into technology. So we also have to think about, actually at the end of the day, how much value or value-based care, as it's the talk of town, how much of the cost benefit are we giving to the patient versus investing in those things. So those are some of the things that I want us to think. Having said that, let's spend a moment on why did we end up here with technology and so much discussion around technology. I think I remember Sangeeta said in the morning that technology is just a tool, and I think many years ago it started with collecting data, inputting data, analyzing data, which was what basically patient-centered care was. You go to a hospital, they see how much data can they collect from you, see the patterns, see what can be done, and that sort of led to becoming a person-focused care. For example, today we have these Fitbits, these watches, so it knows our sleep cycle, it knows how many steps we did, it knows how much of time, how is our heart health, what are we eating, things like that. So yes, technology is helping us do those day-to-day and become more conscious. But I think we're at that point where we also have to ask, do we humans take the back seat and let technology drive us? Or we still stay at the forefront, yes, use technology to help us, but still remain humane, still remain at the center. And that's basically what, if happens, it leads to humanizing healthcare. So I think right now we're somewhere at the orange circle, which is person-centered care. So it's a decision which we have to make on how we are humanizing healthcare, but in the digital age, and that's why this topic. Now, what does that mean? As my colleague here said, that it's all about integration. So there's a role for everyone to play in this. As a regulator, there are countries where it's the private sector which drives things. A place like India, where private sector does the innovative work, problem solving, and then the regulator supports it, as we saw in the morning. Sangeeta talking to the minister, and the minister saying that yes, these are the things we're taking in from Apollo and trying to integrate. So the government, of course, plays a very crucial role. From that point of view, regulators have to look at policies. You have to look at where the private sector should draw the line in terms of integration of technology, but also care for today, care in the present moment. Yes, but if you have to develop technology, if you have to develop health, you also have to look at creating that balance between learning, making mistakes, letting technology make those mistakes, but also not harming patients. We are in a patient safety conference. The patient safety is still at the forefront, even with technology. If you're a hospital, I think what I see is, and I'm speaking as a marketer now, we see is hospital X says we're doing robotics, and then hospital Y says, how do we compete with these guys? They say, okay, we're going to do this. Hospital C says, you know what, I'm going to go and start a fellowship program with this. Hospital D says, I'm going to just get affiliated by this. So rather than focusing on competing with your neighbor and finding a brand differentiator, I think the starting point is for you to know what you are in, what's your mission and vision, where you want to head, what do you think you're doing versus what you're really doing, and where you want to go. Basically, in simpler words, you have to look at your journey cycle, your care continuum, your patient journey cycle as your own provider, and then set those parameters of where to go and how to go. As people, I think we also have to take care of our health, but also build a sustainable platform for the future generations, which means if I go to a hospital and I'm used to getting myself checked in with someone at the administration desk, rather than doing it manually, I should have some set of curiosity that, this time I'm going to go and try and register myself digitally. Because unless, as people, we don't experiment, we don't let the experimentation happen, technology will not make mistakes. If it doesn't make mistakes, it won't learn. So you have to also be open to trying those things, but not at the cost of your health, not at the cost of compromising your safety. So that's where I think we draw the balance. And of course, there are supporting stakeholders as air ambulances, insurances, medical travel people, and all those related people in the healthcare ecosystem. So, as I'm saying, everyone has to focus on their own uniqueness, everyone has to focus on their core value, and everyone has to look at from there, how can we blend in technology and empathy, help focus on improvement, but also serve the purpose of treating the patient in front of us. So that's where I will leave that point. So in 3 simple steps, what I'm trying to say is, look at your own patient journey, evaluate what you're in the business of. From that, yes, focus on a more connected care model where you can integrate technology, try and have new delivery systems, but also look at how and what you can continue to do, what you do. For example, today if so many people, if Apollo is a success story, so many people choose Apollo is because they have a personal sense of emotion or some sense of connectivity which is humane, that they choose Apollo over something else. They don't choose Apollo because of a robotic surgery which Apollo is offering, which of course is great, but it's also very humane. The choice is also very humane. So you have to focus on that. And as I said earlier, your marketing and communication strategy has to focus on empathy, because if you are good at empathy, if you're good at curing the patient, you naturally are growing yourself. Because believe me, as a marketer, we do so many different types of branding, marketing, communication strategy, but till date, the best marketing strategy is word of mouth. If a human being goes and tells another human being, I went there, I had a good treatment, the vibration that you licked more than your words is what the person picks up than any billboard or anything that you can plan. That's how simple it is. So with that said, you see, I'm depending on technology. And it is stuck. Hello, excuse me. Can you just go to the next slide? See, I need a human at the end. Next slide. Yeah, just press once more, please. So all I was trying to say is this is an international travel journalist who does a lot of write-up on medical travel and patient safety. And even she says, and trust me, I have not made her write this, but she really says this, that brand loyalty will hinge towards safety alone over everything else. So if you're in a patient safety conference, we need to also think that nurture, empathy, and attention to the person is the founding of safety. And with that, I will just ask you once more to press that slide so that I come to my last slide. Yes, so all I want to say is love, kindness, warm-heartedness are the keys to health. Thank you.
This is your presentation. It's just your presentation.
This is my presentation.
Thank you, Mr. Sandeep Sharma.
Thank you.
Now our last presentation, I'll just give a little bit of background. Initially, it has to be presented by Babjit Singh from the Red Ambulance Company, but he couldn't make it. We have another colleague, Mr. Suhas Kulkarni. He is a Chief Product Officer in the technology firm. The background is simple. It's mainly to enhance the emergency care and emergency transport services across the region, and for that how this technology will leverage the function of emergency services. I remember when in India the first 108 was started, they were depending on the satellite geographic mapping. Now, the technology was difficult to establish, but it has made a huge success in a couple of states. Advancing into it now, so many 3G, 4G, 5G technologies are there, and Mr. Suhas Kulkarni, being technology head, is going to discuss on this 5G technology in the healthcare. And also I will request him to introduce himself, because we just came to know about his presentation. Thank you. Mr. Suhas.
I hope you all can hear all the way on the back. So I'm not Prabdeep Singh. He's the founder and CEO of Red Health. My name is Suhas Kulkarni. I function as Chief Product and Technology Officer. And we are building India's 911 emergency system, medical emergency. And what I'm going to present is going to blow your mind. The future technology, all of the conversations we have today, it's here today. And a bit about my background. Previous to Red Health, I spent last 25 years in San Francisco Bay Area. And my last 6 to 8 years, I was one of the earliest at Uber. It was my team that built Uber's dispatch engine. And the first ever trip that happened for Uber, it was my team, and I grew the team to scaled it to 600 cities across the globe. So thanks for the opportunity to be. I find myself to be surrounded. I'm an engineer, surrounded by doctors at this conference, but I'm going to talk about technology at this moment. So we are Red Dot Health. What we have built is an operating system for emergency care and response. Dr. Joel talked about integrated continuous care and hospitals beyond the walls or without the walls. It's all about the phone call that comes in, the emergency phone call, and what sort of a pre-hospital emergency care and how do you stabilize the patient? It's all about patient safety. So what I have for you, it's a live demo. If you were in the US, sorry, it will work. So if you currently dial 108, you know the experience. It takes about, it goes through an IVR system technology, and there is no human behind the scene. And somehow one of the persons reaches out and says, hey, we will send you an ambulance, or it may or may not show up. And it takes about 40 minutes. And in a place like Bangalore, you know the traffic conditions. And even if you call, something were to happen to me at this moment, what would you do? You'd probably call a front desk or call a emergency line of a hospital nearby. But it takes 20 minutes for the ambulance to get out of the gate. And imagine the ETA, the response time to reach the patient, and needing that care. If you think about MI or stroke patients, which is truly, truly time sensitive. I'm no doctor, but I know enough that these are time sensitive things that you need to take care of the patient. So what if I dial this number? I just dialed the number. Thank you. This was a test call. So if one key takeaway is, if you get out of this room, is remember the number, save people's lives. So I'll give you that number later. But that's not the topic of the conversation. It was more of a, felt like I'm a salesman, but that's not it. We actually truly save patients' lives. We have transported around 400,000 patients, around 75,000 critical patients. So there is a lot of experience curve we rely on. And the technology that I'm going to show you is a result of that. So how we see the world, it's all about trigger, triage, transport and treatment. And Dr. Joel talked about continuous care, delivering remote care to the patient. It starts with that phone call that comes in. Imagine my father is 82-year-old, he falls down and they can't remember the numbers. What if there was a button that my dad could press? So generally I tell my mom, don't even call me, call this number. Or I press this button and help will arrive in 15 minutes. And that's what we are building. So the trigger part is all about, can you detect when there is an emergency? In the country, there is a lot of detection mechanisms, but who is there to come and help you? That is largely missing. So that's what we are taking care of. So you saw the response was in 1 second. Again, to humanize, we operate with a lot of empathy, speed and reliability. Those are the core values of the company. But the key part of it is, there's a live person speaking to you all the time throughout the journey. That's the game changer. And so essentially, imagine whether it's a collision detection, a smoke alarm going off. Imagine like the SOS, red SOS, gets triggered and the help will arrive in 15 minutes. So that's how we are building it. Then the second part is the triage. This is where we have enabled AI that assists the call center agent to triage the patient. Because think about this, even if an ambulance heads in your direction, it takes about 15-20 minutes. And how can we, what kind of instructions can we provide to the patient so that we can stabilize the patient until the paramedic arrives, right? So that's one of the major gaps, something that we have solved. This is a proven tech and it works, and we are in 20 cities and reach over 500 cities across India. And we are working with all the major brands, hospital brands across the nation. And 5G is the major infrastructure that drives all of this. And transport, we have truly world-class ambulances. These are smart ambulances that you can rely on. And then the treatment part, this is where I'm super excited about how we are sending real-time patient vitals as well as video feed to doctors in the emergency room. So the topic of this conversation was more about how good are we in ensuring patients' safety, and how can we bring them to hospital in a safe and reliable manner, and within the golden hour. That's the critical part of it. So I'll skip this part in the interest of time. I probably am the only one in front of a coffee that you will be having after this. So essentially, currently the gap is something that we are solving. You saw the response time within 1 second. If I were to continue on that phone call, in 20 seconds the ambulance will start moving in our direction, wherever I am. And this is the entire. I love this slide because hospitals, enterprises, and any users. We have an API that we have built which gets embedded into every device, connected device or the wearable, and that phone call. So all of that and emergency response flow gets kicked in. And we have ER modules that we have built for hospitals. How well are you able to communicate with the patient? Right now there's a gap, huge gap. So essentially this is what we have built, is the dispatch engine. One of the key parts of it is, this is the dispatch part. You ask for information that is critical to dispatch an ambulance. So all of this in 20 seconds we are able to dispatch an ambulance. We have built a supply positioning of these ambulances across towns, where within 15 minutes, wherever you are, you'll get an ambulance. And it's completely AI driven, which means if traffic conditions change, these ambulances, so pretty much, and red triage, this is where we think we have made a huge impact in this space. If you think about when that phone call comes in, we send the ambulance first and then we ask questions later. And as part of this, we'll go through, in this case, it's a patient reporting, or a caregiver saying, hey, this patient is unconscious, breathlessness, or a chest pain. And the AI will tell you, ask you a little bit more questions about, hey, can you see any signs of injury or trauma, and basic yes and no questions. And if we have more intelligence about the patient, imagine I've called Apollo's emergency line, and it's possible that me as a patient, there may be a history about this patient with Apollo, and that information can be fed into AI. Now imagine all of the instructions that we are giving, these are not prescriptions, these are simple instructions, because we are not clinically trained, we are not supposed to do that. So these instructions will at least help stabilize the patient until the paramedic shows up. And as we go through this triaging process, you can also see there's a live video feed from the patient coming to the clinical, trained agents in the call center. And so you need work, visually you want to see the patient, and the same feed goes to the doctor in the ER. The moment the phone call comes to emergency line, we already informed the doctors in the ER, there's a patient coming, and all of this intelligence is sent to the ER doctors. And this is sort of how the flow would look like, and this works at this moment. This is a proven tech. Many of the hospitals are prototyping it at the moment. And we have just launched 5G smart ambulances. And this is what you shall see. This is actually, this graphic is not a real one. I have a video that I can show you later. You can see these are the patient vitals. These are coming live, and this information is fed there's a Red ER console that is available to all the hospitals. If you are a ER doctor, you shall see there could be, these are the 6 ambulances that could be coming in your direction, and the doctor could double click on one of them, and the doctor can actually speak to the paramedic. There is a two-way communication. There is a live video feed. There is SpO2. There is ECG. You also want to know what drug is in that syringe pump, as well as ventilator. So all of this is real time. There is no buffering. So technology plays a huge role, because we follow the ABC framework, which is airway, breathing, and circulation. All of that information is so critical, so that the doctor is already know what to expect. See, here is one gap across all. I've spoken to many of the ER doctors and facility directors across the nation. As the patient arrives at the doorstep, it takes yet another 15-20 minutes to treat the patient, because you have to go through all kinds of tests. You have to organize, coordinate, page other doctors. In this case, imagine if it's a stroke or a MI case, we send the patient directly to the cath lab, because all the vitals are in. And that's the magic we are creating. And we are doing this at scale. And this is super critical, because doing it at scale, a lot of things can go wrong, right? And you have visibility on the patient. Can you come back and audit, did we actually handle the patient correctly or not? And as I speak, we are going through the JCI prep, and we are excited about that, because it's all about, Dr. Joel talked about leadership commitment, something that we have, because empathy is one of our core values, and it starts with that. And with that commitment, then we are able to improve the processes. So from ambulatory care, we are not just we are transforming ourselves into not just an ambulance company, to a more of a clinical services company. It's because it's all about, delivering the care remotely and also ensuring that the pre-hospital assessment and care is truly JCI standards. Something that we are doing this at this moment. So I'm excited about this, and this is the real-time view of this is city of Hyderabad. Where are my ambulances across the nation? Let's say if this were Apollo Hospital, they want to know where are my ambulances. Literally, I can click on one of them and see who's on it, which patient, where is the patient going, and we are working on. If you double-click this, there is also a live video feed into the ambulance. I talked about ambulances spread around the city. They all carry the mobile app, similar to how the drivers, Uber drivers carry. So literally, as we click that dispatch button, the pilot, the paramedic, and the vehicle, they start moving at an instant. So one of the things why we are good at this is it's all about call to wheel. The moment the call comes in, and the wheels should be moving in a split second. So we have built the tech to ensure the pilot, the paramedic, and the vehicle are together all the time. Because if a pilot moves away 10 minutes away from each other, then it starts buzzing. So that because it's all about operational excellence on the ground, you may have built the best of technology, but if the operational discipline is not there, there's no way this will work. So a lot of care has gone into ensuring patient safety and reliability. This is where this is truly a game changer for EMS system as we see today. So and there's a WhatsApp and SMS journey as well, where when you make that phone call, patients want to know where is my ambulance. Can I speak to the pilot? Can I speak to the paramedic? Right. So this is a major gap as well. So we have that in place, and a video feed also comes to the the patient. So with that, that's the technology we have built, and the future is here today. So we are at this moment rolling this out across top 20 cities, and we have reached over another 500 cities in the upcoming months. So open for questions.
First of all, thank you on behalf of the audience and myself for a wonderful presentation by all of you. You all have mastered the session, and certainly it's all about integrating the technology and healthcare innovations. It's like innovate, integrate, and implement. So you innovate, you integrate it for in the patient safety and ethical framework, and you also implement it for the best patient experience and effectiveness. This is all about the session. Wonderful session, and I will invite now questions from the audience. Please try to be precise, one or two questions to each. Thank you.
Thank you for having us.
Thanks.
I'll tell you what, I'll get us started if that's okay, since I don't see anyone. I'm an emergency physician, so I'm well aware of what you're trying to do, and if you're based in San Francisco, you're clearly trying to make up for differences in how systems are organized here in India, so I applaud that. My question is, and it really applies not just to your scenario, but what I see everywhere else when we start talking about AI. If I understand correctly, you have AI algorithms helping both the patient or their family, as well as the paramedics, deliver care. How have you validated that AI, and what are the outcomes associated with it that you're monitoring? Because essentially, it's a medical device, or pharma, and this is one of the issues with AI at the moment. So I'm not picking on you, it's just a great example.
It's a great question. This is something that we have. So in the case, see, if you look at out of 100 phone calls that come in, not all of them are emergencies.
Of course not.
Right? So maybe one or two. And when we know it's an emergency, we have clinical doctors in the call center. They come online.
Okay.
So, and then they are assisted with, because it's a panic state, we need to immediately dispatch an ALS or a BLS, because patients come in and say, I have an emergency, but this could be someone breaking their leg, right? And what we do is every time we deliver these instructions, not prescriptions, we have a medical operations team, and all of them are emergency doctors. We actually literally go through and audit and verify every case that gets, and then as we are serving every patient, our AI is constantly learning and improving, and the precision and accuracy is increasing every time. But there is definitely, you can't just blindly give these instructions.
No. So you answered it really well with the part that you left out, that you have medical backup on. And really my point is, we're seeing AI being rolled out in healthcare left and right, and there's great innovation, and here's an example of it. But there is there's really, if in effect we are rolling out medical devices or drugs, it's the equivalent of that, without the same oversight and development that we, clinical trials regarding, a new drug or a new therapy. AI is not under that scrutiny yet, and we're all looking at it and saying, we're not doing that, yet we need to, and the government's very late to step in.
Absolutely.
So
it's a great question. It's a very important one, and the patient-first attitude needs to come in. That's why we have a live person speaking and a trained physician, on the call.
And that brings me to a connected question. I mean, we did not plan this when you were speaking.
No, we didn't.
I think everyone can hear me, right? So my question to follow up on that is how. So you showed us the map. You said that these are where all your all the three of them are there. But let's say you end up taking a patient to one of the hospitals. How well is the staff of that hospital trained or integrated to work with you? Because you might have done an excellent job with your internal operation excellence, but how's it being integrated with the providers?
Yeah, I think this is a gap in India, and because I think we may as well do a good job of improving the response time, right from the call coming in, call answering time, to call to wheel, then call to reach, call to pick up, and then drop off as well. We are also working on green corridors to go past the traffic conditions, and that's a prototype. But we will do because that's a major chunk of how much time is wasted. Think about the golden hour, right? So our first job is to make sure we bring that patient safely and reliably, and within as much as possible in 30-35 minutes tops, and at the doorstep. And then the next phase of the conversation, you saw red ER console that we are building, because you need that communication and coordination happening ahead of time. As the paramedic has picked up the patient, you have enough intelligence about the patient. You are transmitting the electronic patient care report, and there's a live video feed coming in. So now, more and more major hospitals, especially major brands, they want that consistency of patient experience, right from the phone call all the way. So that visibility and the way we operate with transparency is super critical, and that's where we are learning a lot from the facility directors and the operational heads, as well as the ER doctors. They are telling us what to do, right? And we are literally going through that. And we have a med ops team within our company, and who are trained, who've been in this space for a long time, and we are slowly beginning to solve that. But once we bring the patient into the hospital, that's where the JCI plays a huge role, and we may be the only ambulance, like JCI accredited ambulatory care in the country in the future, very near future. And imagine that experience continues through into the hospital, and that's the overall the continuous care that you talked about. I love that terminology. That's what the JCI brings, and all the major brands want in on it, otherwise you'll be left behind, And especially the 5G, if you don't have all ambulances across the nation have to become smart ambulances. In a couple of years, your mom and pop ambulances that are standing outside will be left behind,
So I have a question. How do you connect with hospitals? Do you have some sort of an MOU with hospitals, or how is it? And one more question for you, sir, that you mentioned there's a shift in the way the treatment paradigm is shifting towards homes and preventive wellness. But in India, these things are not covered by insurance. I don't know who is going to answer that question, and how do we go ahead with that also?
Go ahead.
Yeah. So maybe I'll answer both the questions and then pass it on. All the major brands, they partner with us, and we have contracts in place where there is definitely certain SLAs that hospitals want us to, behave in a certain way, whether it is a response time to, all of the protocols that you need to follow, even to take a patient. How do you, move the patient in a stretcher? It's also, it's something that, how well are you trained? So all of those SLAs are completely digitized, and we have SOPs and protocols that we follow, and it gets audited every week. And we have given the power of tech is that every action taken on the ground is monitored, and there's data to prove it. So we are fully transparent, and then we send those reports in real time to the facility directors. And on the second one, our vision is, if a patient is coming through an ambulance, we want to make sure that patient is covered, so that you just walk through. That's the holy grail of the patient experience we want to bring at some point, where we could be partnering with various insurance companies. And if you're coming with the red ambulances, we know this patient is covered in this hospital. So it's very much integrated. It needs collaboration with three parties as well. But I think I can see that happening. It's not it's doable.
So,
Go ahead.
so I'll just add on the insurance bit.
Well, I'm going to do as well too. Yeah.
Go ahead.
Well, so two pieces to this, because connects both thoughts. So in the United States, the insurance is slowly coming too, right? This is technology and forefront of care. The insurance is not always, or the payers are not always aligned yet. And so the fact that I highlighted that CMS did this experiment for 3 years and has found good results. Once CMS agrees to pay for it, the insurance companies will follow suit. So that's sort of how it starts. And listening to your presentation, and as I've learned more, I've been to India many times, but this particular visit, a lot more about the development ecosystem of how private innovation leads the government. This is a classic example, because in the United States, if you understand how emergency medical care is provided, it is primarily a government function. Whether it's the state or usually it's county level, it's their responsibility to provide 911 service. They integrate it within all the hospitals in the community and the trauma centers and the like. And it's one number. It's in the U.S. it's 911, but here it's the private innovation that's going to drive it to the government the other way around. And the payment will follow the same suit is once it's established. So it's fascinating from a development standpoint, because much of what you described, other than the app itself, is already existing. I mean, you lived in the States for 25 years, and I'm just sitting here fascinated of, wow, it's going to take private innovation in order to drive it into the community. And I think the payment will follow the same way. So I think that's the pattern. And but it's a great question, because like anything new, you got to figure out who's going to pay for it.
Yeah. So I'll just add on that, because he made an interesting point which goes back to your question. Now, globally, fundamentally, it's just two broad types. One, where primary, secondary care, and tertiary care is covered by the payer, the national payer, or it's private, as it is in India. Now, the classic example of that is the NHS, because we do a lot of work, and in Dubai, with the DHA, the Dubai Healthcare Authority, we do a lot of work, and the fundamental issue right now is outstandings, co-pays, denials, all of that. And I was just telling Joel earlier today that Italy, where all the patients are covered now because we work with Ministry of Health in Rome, is now saying, you know what, if you want government-sponsored insurances, this is the wait time, this is what you'll get. If you can wait, please do. If not, these are the lists of private insurances you can buy and facilitate the treatment in Italy or through medical tourism. So from that standpoint, countries which were very dependent on payer models are also getting private, as he said. And that goes back to his point that, if you're creating a private ecosystem, and if they're able to successfully work with private insurances, it can so beautifully be integrated with the private insurances. Actually, it's easy for India because most people pay out of their pocket for healthcare. Unlike the UAE, unlike the US, where it's a complication because the government-sponsored payers are supposed to pay for it, but it's not happening, and then you're privatizing it. So it becomes even more lucrative.
Yeah, and just to add, since we do a lot of work across in almost all geographies, so I have a point of view on that, but specifically looking at your example, which kind of brought us a lot of talks feeded into reality. So from coverage standpoint, I think there are many coverages that are available. There are, you have in-network providers, you have out-of-network providers. If you want to pay a little more, you can go to a provider who is not in your network. Especially after COVID, we do have a virtual first initiative where you have care plans that are covering your virtual care as well. That might include ambulances as well. So there are provisions like that based on your eligibility, your age factor, any other chronic disease you have. You can be eligible for Medicare, Medicaid, or if you have an employer insured plan as well, you can be dual eligible as well, which is very common in the US that I've seen. If I'm meeting the age criteria, plus I have a private insurance from my employer as well, there is a coordination of care and a shared component of cost that we share, and based on that you are able to kind of tap into different avenues. And I think we mentioned Medicare Advantage, which is a very, very lucrative growing market where we are trying to provide cost-effective, good healthcare services to people who are in the the aging population. But I had a specific question, and it's coming from a personal experience on this kind of solution, which we experimented in 2016. So how are you detecting false positives and false negatives today? And if yes, from your workflow and operational standpoint, does it get you into a conflict? Maybe if not now, but in future, have you thought through if it's not an emergency and if it was covered as a part of an insurance? So does it lead into payment conflicts, and how do you resolve that?
Because it's all about empathy. That's what drives how we operate. It's okay for us to be, even if it's a false positive, we don't mind it. We bring back the ambulance. It doesn't matter. It's worth it. And the fact that we don't want to leave any element of doubt, and there are always, you have to believe in a folks don't necessarily do these, that's a totally different conversation. But as a company, our policies are very straightforward. It's, if a phone call comes in, get the ambulance out there as soon as possible, and we'll think about the rest later. And with that as the benchmark, then we work backwards. How do we, because we have a live agent speaking to the patient, we would absolutely know what's wrong with the patient. Is it true or false? Before then, the ambulance will be moving maybe a kilometer, but we can bring it back.
And there's a route optimization component to your solution as well.
Yeah, absolutely.
In context,
yeah. So we actually work with we are doing a ton of experimentation around how do we reduce the time it takes to reach the patient. So there is a lot of innovation undergoing. Hopefully in the next conference I'll have something for you all. Yeah.
One interesting small quiz for all of you. And the speakers will ask you one question. If you answer the question, there will be a little gift given to you. So let's do this. Anyone can ask question to the audience. If they answer, they will be given a gift.
Any question?
Yeah, question relevant.
How many of you work for an accredited hospital?
Anybody?
No, anybody, I accredited, okay. How many JCIs? Okay.
Okay, if we're doing that, how many of you have heard of eMarsh Healthcare before today? Wow. Okay.
I'm glad I did, though.
I'm not going to ask how many of you have heard of Accenture, but does anyone happen to know who has been in the US healthcare, that which is the largest hospital chain, private largest hospital chain, or largest insurer by revenue in the US market? I'm sure the latter is pretty popular. Any guesses?
Can I answer?
Yeah. I'm not going to give you any prize. Dr. Jones.
No.
Is it Elevance? Elevance?
Elevance, erstwhile Anthem.
Yes.
It's not the largest, unfortunately, by revenue, but you could guess a competitor starts with U, umbrella. It's UHG, United Health Group, which is largest, I think over 320 billion is their revenue annually. And the largest private healthcare chain in the US is the HCA hospitals.
Maybe I have one. If you need an ambulance, do you know which number to call? May not be the right response you will get. Go to Red Dot Health. Punch your number, you will get the number. 1-800-211-111.
For the sake of making this easy, does anyone know when is International Patient Safety Day? Come on. No? September 7th? Yes, that's correct. So,
Okay, so
we can share the gift.
Okay, please come. You can still ask, we have 2-3 more presents are there. Thank you. Okay. So let us conclude the session. We'll have one photograph with the. And thank you so much. So crowd also, the audience has been very interested. Thank you so much. Please.
Thank you. That's my. Thank you, sir. Just one more from. Yeah. Thank you.
One important announcement for the delegates. If you have not scanned your QR codes today, please get it scanned, because that's an attendance for your for the day one participation. You have to do the same thing for tomorrow also. Only then you will get the participation certificate on the application. Yeah, same place.
That's a good thing.
Thank you, ma'am.
Thank you so much.
Cholo, boss. ఆపలేదు పవర్ ఇచ్చారు ఆయన ఒకసారి
Thank you.
Doesn't matter. It's it doesn't matter whether you're a single provider. Yeah. And I'm very careful when you mention that I asked. Remember my answer? So it was really fun. It was actually really fun. Panel moderators. I did one thing to tell a patient. Advice on hospitals. Did you tell oh, and he needed anyone else too. I said, I should have said care. Some, our standards are higher. Doesn't mean NVH is a value added. So I will never downplay. Yeah, that's really what it is. You can get JCI, you can say JCI interpretation, use it as an advertising base, and never really embody it. Right, and never embody it, and yet you can do a different one that may be, let's say, easier, but you absorb every benefit. I don't just play NVH or the other. We're starting them up again, so we're in Cabo. We're planning to offer tracer trees. So as a pre-concept. Yeah, so I can tell you what we're going to do, it's going to be limited, so it won't have to be a
independently provide emergency care.
We should connect. Yeah, no, we'll 75. No, we have an office last March. We remember that's to get. So we've heard that now a lot. We have not had a great we've also but I'm telling you, I'll be speaking pleasure. It's nice to meet you.
All the best to you all.
Thank you so much. Pleasure.
Sure.
All the best to you.
Well, thank you so much.
You are?
You're welcome. My pleasure. My pleasure. Thank you. I need a nap.
Either that or coffee.
Thank you.
Spoke very well. You're not a clinician. I'm a biotechnologist.
Oh, you're.
He's a clinician.
You speak like a clinician.
I'm usually with clinicians all the time.
Joel, it's fine.
Nice to meet you. My name is Deepak Reddy. I'm one of the stroke neurologists in Peoria, Illinois. We're one of the busiest stroke centers there is.
Oh, okay.
What are you doing here?
I kind of spent a lot of time here. My whole family's here.
Okay.
So I just stumbled on this conference and I was like, oh, I do it.
Well, I was just wondering, you're closer to you because I'm based outside of Chicago.
And we have an office in
Yeah, we're based in Oak Brook.
Oh, that's right.
I'm very
So,
Okay.
yeah, so he goes, Peter, what the hell are you doing here?
Yeah. No, I mean, I know, odd location. location, but extremely busy stroke center. But I really appreciated your words about empathy. Thank you so much. If you work with the stroke population, you know that it's very high mortality. The other thing that I love that you said is, you're right, my residents are getting dumber, and they're weak. They're weak because they don't know their position.
Yeah,
so I tell them, thank you so much.
Yeah, I was having, yeah, no, it's funny. Okay, so I'm going to jump in because last night at dinner, for some of the visitors in Singing Room was talking about all the AI they're rolling out and how great it is, right? And she's focused on it's just a tool, and it's, the physician is still ultimately the decision. And I looked at her and said, yeah, but that's not how it's going to be used. I said, if you think a physician, a young physician is going to question what's coming out of an AI function, I said, they blow past, you blow past the drug interaction recommendations. You think they're going to question the AI? That's naive and idealistic, is the way it's at 2 o'clock in the morning. Some physician is not going to, if AI is saying do this, they're going to do it.
Unless those treatment paradigms are valid. What if they were based on language models that include the guidelines, like AHA guidelines? Then perhaps.
But they have to be validated, right? They treat it like a drug. It's treated like a drug.
And science, medicine is ever evolving. There will be some percentage of uncertainty that the doctor is giving the patient what's for replacing that.
That's my thing. If AI was treated like a drug or a device, there would be a lot of rolling out. Now, on one hand, that would hit the development, but the same token is with making it safe.
So we have aspiration
That's what we're doing.
Yeah, we're actually talking with them.
So we do things with Fidelity and Braintree, which
we
talks
also think
about
whether to
integration. We're doing this whole podcast.
whatever it is. But for the older solutions, we're not really
It's all about
optimal. But I felt this is
the human policies which need to remain and not change. No matter what the AI does, no matter what the technology does, these have to stay. Period.
I'm not sure about comparison.
I think there needs to be human supervision along with that AI-directed treatment paradigm that you get initially.
This is a human plus machine, like complementing each other.
Right.
But obviously, out of curiosity, wanted to ask you, do you also get to review or get involved into electronic medical records world as well, like Epic?
No, we don't. We sort of stay away from some of that. I don't like any of them.
They're all fancy, but they all have their inadequacies.
The problem is why were they developed?
To digitize hospital processes?
No.
To solve problems.
No. Why was the EHR developed?
To have the longitudinal health history, continuity.
Maximize reimbursement. First and foremost. That is why they're so cumbersome. Because it's all about capturing the information reimbursement, not for clinician use. And the clinician use and desires are afterthoughts, but they fundamentally were designed to maximize reimbursement.
You said that's partly why it feels like a cluttered interface.
Correct.
Regardless of what platform.
Right. It doesn't matter which one. They're all evolved from that aspect.
That's a very interesting perspective.
At least in the U.S. Now, I can't speak for different
That does happen in the Middle East. That does happen in the GCC.
But there's a lot of regional developed and homegrown systems that may not be as Cerner, Epic, and the ones that that's what they're designed for.
Right now, Dubai Healthcare Authority has $1.6 billion outstanding with the Cerner integration. And I'm just talking about one state.
Well, I've watched my friends go through the VA and DoD integrations.
But then the packaging is good for all EMRs now. They just Google or search why EMRs. Reimbursement never comes up at all. I mean, what you say makes sense.
No,
but it's all talking about medication errors, patient
Continuity of care, EHR.
Which one do you use?
In the US, Epic is number one. Globally, market share standpoint, and Cerner.
Cerner, I think, is bigger. Has a bigger international presence.
What Epic does is it says this is the standard, but we're going to go and sit inside the provider and then build it. Whereas Cerner has it all built and it's taking it as is and then less integration.
One interesting thing is Epic kind of workshops the provider rate.
Exactly.
I have physician friends in US who are not shifting jobs just because the other job is on a different EMR. He's so used to Epic.
Yeah.
The adoption itself in the beginning was so difficult when ACA or affordable care came in, right? To the wire, timelines kept shifting in spite of penalties and whatnot. So, but now if you ask them to get off it,
And now,
Well, it's
why Healthcare is hiring Oracle to solve the problem of
at
least then I use the CPRS.
That's how it started. They went in to solve the problem and they said,
Yeah, no, it's funny. I go
So
by this.
the
My
vision is to
initial.
provide now front office, middle office, back office.
This was good.
Very nice to meet you.
likewise. Please stay in touch. Please stay in touch.
Apologies, I'm not carrying the card, but we're adding on the
Scans on the back.
Awesome. Thank you so much.
I've been in that window so far out. Last week, I went to 20 an hour after I thrombolized. Risky, but things were favorable. Patient woke up. Yeah, they're going to be debilitated anyway.
Thank you.
Let me know when you're in the area. Shouldn't have to come out here.
Whenever you're in Northbrook.
I'll hit you up.
सर जाने के लिए बस नहीं थे सर ऐसा कुछ नहीं हुआ ऐसा कुछ नहीं वो तो बोला मैं सर वो बोल रहा है कि मैं सर बोलेगा मैं स्ट्रोक कॉन्फ्रेंस में जाऊंगा मैं जाओ ठीक है कोई पैसा देंगे या हाँ नहीं सर वो सब कुछ नहीं है सर वो हम किसी को भी नहीं देते थे वो तो हम किसी को भी नहीं देते बोला मैं जाऊंगा सर स्ट्रोक कॉन्फ्रेंस
I'm having trouble trying to figure out like where to go with this, but if you had to,
ऐसा कुछ नहीं है
he makes my job. We can
I think he told me मैं सर स्ट्रोक कॉन्फ्रेंस पे जाऊंगा मैं बात करता हूँ सर हाँ मैं बात करता हूँ नहीं सर किसी को भी नहीं
Yeah, so as soon as I work for it, I'm one of the. I don't even. Why don't we change the LinkedIn? Please, actually, maybe I'll just send you a testament. And this is Kanchan. Very nice. Very nice.
सर इधर
Your company is usually going up much though. So I'm one of 3 stroke neurologists.
संजय मोहम्मद की बात कर रहे हो
Stroke volumes.
संजय बिस्वा
That's funny.
I want to hear more.
संजय मोहम्मद वो सर मैंने न्यूरो बैंगलोर में है सारे न्यूरो फिजिशियन को नमस्ते मैडम मैं अभी बात कर लेता हूँ अभी बात करता हूँ सर अभी बताता हूँ सर
We had a problem in the start of the discussion. We had a level ultimately the goal is simple. Okay? So with this we are coming
सर ये स्ट्रोक कॉन्फ्रेंस है बेसिकली आपने बात किया था
they should have been announced this start, so that
स्ट्रोक कॉन्फ्रेंस वही करने के लिए ओके अच्छा ओके सर मैं अभी बात करता हूँ मुझे लगा आप कॉन्फ्रेंस ठीक है सर मैं बात सर ये एक स्ट्रोक की कॉन्फ्रेंस यहाँ होल्ड कर रहे हैं जैसे उसके लिए बात कर रहे थे नहीं सर ये मिले थे इन्होंने वो पेपर शायद है वो अभिजीत सर ने इनसे बात करी थी और इन्होंने मेरे को बोला था उन्होंने बोला है कि हम कर देंगे कुछ कॉन्फ्रेंस में ये इतनी जल्दी नहीं है सर मैं जब आता हूँ तब बात करता हूँ हाँ हाँ मैंने बता दिया सर मैं अभी बात सर मैं मंडे को आ आप अभिजीत से मिले सर को मालूम हम लोग मंडे को आते
second initiative that is that smart antibiotics smart that when you look at the names of antibiotics at least 80% of most disease access category we are talking about primary and secondary
this last year also this side sessions
so they are aiming at one antibiotics smart
लास्ट वाला जो क्वालिटी वाला बोला था
Were you in Bengaluru before?
because you will have these people who have matured and become clinicians
That's commercial level.
He studies from there.
So he's a very well qualified guy.
He did my MD from
Yeah. You also.
Amazon. I completed my MD.
Working here also.
Yes. 40 hours. My both sisters live here. One lives in Whitefield. Electrical charges from university. Another sister stays in Philly.
सर सुबह भाई कौन सा नाम बोला बेलमपुरा
Bengaluru.
How far is that?
Bengaluru is close by.
My son used to. Full Apollo blue here. How you all enjoyed?
Yes, sir.
Actually, I forgot what my topic is.
Diagnostic errors.
And diagnostic errors. जो मन में आएगा
Diagnostic safety, is it so simple?
I've got two questions to answer. एक तो बहुत dangerous है. How bad is diagnostic?
What is the burden of diagnostic errors?
First floor.
पहला प्रश्न
कब वो नहीं जो हॉल 1 है ये हॉल 1 के ऊपर हॉल 3 है तो हॉल 1 में के राइट साइड में जो जहाँ पे गेस्ट लोगों को खान वीआईपी लोगों को फ्लाइट आया था उधर ही लिफ्ट है हाँ उधर लिफ्ट है लिफ्ट उधर ही है बाकी गुवाहाटी वाला माल लेके
How big is the burden of patient harm due to diagnostic errors and unsafe diagnostic practices? This is one. Secondly is how do you induct new technology while ensuring diagnostic safety? And third is in moving from zero error to zero patient harm. अच्छा क्वेश्चन है सर. এতগুলো চোতা দেখা যায় কিছু থাকলে লুকিয়ে লুকিয়ে দেখতে হবে. ওটা ছোটই আছে মাইক লাগবে.
There are multiple such small halls.
Yeah.
Yes.
Where is our nursing team?
Nursing another downstairs. There are another section, one nursing.
Having done that.
We heard you during the debate.
अरे one word only I said. अरे सर
सरकार जब माइक नहीं चाहिए था वो
सर तो Dr. Hariprasad sir always gives the mic first to me, always for everything. Please speak.
EPS 1, is antimicrobial resistant only in the developing nations of the world. Yes.
The nursing session will continue tomorrow as well. Same place.
Tomorrow we are tomorrow तो we'll मस्ती sir कुछ नहीं.
You will have to just
lunch के बाद hour. When are you all going back tomorrow?
Third flight.
Have you all booked, have you all asked for transport or not?
Yes.
Ki asbe? Bus asbe? Tempo? Huh?
Bus.
Tempo travelers. Tempo travelers, that's okay.
তাতে ওটাতেই আমরা এলাম এয়ারপোর্ট থেকে এখানে এলাম টেম্পো
But only thing is, না এখান থেকে তো টেম্পো ট্রাভেলার করে গেল।
স্যার বলছেন ওখানে
এয়ারপোর্ট থেকে বাড়ি দুটো কি তিনটে গাড়ি করে দিও যাতে রাত্রি সব ড্রপ নিতে পারে। And madam, how are you all going from airport to home over there?
Foreign is there, so he's arranging foreign is there.
Yeah, ask him to arrange for car. It'll be pretty late.
Ground costume or there is some resistance,
चलो अपना तो स्लाइड फ्लाइट कुछ नहीं है। Come, madam.
Sir, good
Very
evening.
good.
Sir, best of
Good
luck.
afternoon.
Sir, best of luck.
Best of luck. I've forgotten to keep topic. Keep talking and কথা বলতে তাই ভুলে গেছি।
Oh, yes, sir. Best of luck.
You are not a speaker? You should have been a speaker here. वो हमारा तो भद्रमेन के छिड़े हैं। कुछ बोलता हो ना? हाँ, ईगल फिगल देखा लो सब की सब। Leadership. हाँ, leadership.
हाँ. Nursing leadership.
First presentation.
Oh, she was
First presentation was very good.
yes, yes.
First presentation was okay. The second presentation was better.
Yes,
The lady,
she's a group director of IPSC.
lady spoke very well.
But she speaks very well. She couldn't.
She spoke very well.
She speaks content.
Content wise,
She is a group director of IPSC. Punita is a group director of IPSC.
yeah, but she could have done better. I'm ये बोलते हैं ना
Elizabeth Jones.
Elizabeth John, you met? But she had a topic now.
Who?
Major General Elizabeth John. She was the Council INC, this one, president. And then she was DGMNS. Pre-MNS also after that. Yeah. FMC. She spoke on leadership.
Diagnostics से
It was very
eating so simple. Very simple.
she's lost it. No, she will get it.
नहीं আমাকে S bar এর full form बोलो.
Situation, background, recommendation, is bar.
S is for situation.
B for background.
B for background.
A for assessment. R for
Recommendation. Take me. If I forget, I would say from the Florence Nightingale Medal. Tell me what it is.
कब है देखा नहीं देखा नहीं
All my other speakers are all doctors.
Hello.
Down from there. Hey, come in front.
पूरा तुम हाँ এই তো স্যার স্যার এই সাইড পুরো
আপনাকে শুনতে পাচ্ছি যে আমার ইয়ে কথা বলছে
চেপে যান
সেক্টর থেকে কনসার্ট বলুন ম্যাডাম কি বলছেন
My only friend of Ahmedabad.
That's very good.
Thank you.
Namaste, good afternoon everyone. It gives me immense pleasure to welcome you all for this session on diagnostic safety. Is it so simple? As we all understand, the role of diagnostic tests in determining the patient's definitive diagnosis is immense. But what happens behind the curtain matters, as the safety in the diagnostics is a critical aspect of healthcare. As per AHRQ, diagnostic errors across various settings have contributed to approximately 10% of patient deaths. Ensuring accurate and timely diagnosis is essential for patient safety. To further understand what is revolving around diagnostic safety and how well we can contribute, may I please request our moderator for the session, Dr. Neelam Dhingra, to come on the stage. She is the head of Patient Safety Flagship Unit, World Health Organization, Geneva, Switzerland. She has the WHO Transformative Flagship Initiative, a decade of patient safety 2021-2030 at WHO headquarters in Geneva, Switzerland. In this role, she leads WHO's global effort in providing strategic leadership on patient safety within the context of UHC. She has been coordinating WHO global efforts in the areas of patient safety, quality improvement, and risk management over the years. Prior to joining WHO, she served as a medical faculty in a large tertiary care university teaching hospital in New Delhi for 14 years. She also coordinated transfusion and laboratory services after medical and specialist qualifications from New Delhi and UK fellowships. So, big applause for the ma'am. Yeah. With her, I would always also like to welcome our speakers for the session, Mr. Ranadas Gupta, Dr. Malti, and Dr. Preetam K. I request ma'am to introduce the speakers and take the session forward. Thank you.
Thank you very much, and thanks for the introduction. I really appreciate those of you who could come, and that shows your interest in diagnostic safety. So my name is Neelam Dhingra, as I was introduced, and in the next 1 hour we are going to explore and discuss the multifaceted challenges and opportunities which in the area of diagnostic safety. So I will now like to introduce our panelists. And can I have the next slide, please? Be able to go? Yeah, I can take it. Thank you. So So it is really an honor and privilege for me to have very esteemed panelists who bring with them the world experience and expertise in the respective fields of patient safety. And so we have Dr. Preetham, Joint Director, Clinical Administration, Bengaluru Unit, Apollo Hospitals, Dr. Malati, Chief Medical and Quality Officer at the Esther DM Healthcare, and Mr. Ramdas Gupta, Regional Chief Executive Officer, Apollo Hospital Groups. So before I go with the panel discussion, I thought I would like to just frame the discussion today. What is diagnosis? What is diagnostic safety? And I also will be touching upon on the Global Patient Safety Action Plan, which was the other agenda for today's discussion. So as you all know, a diagnosis provides an explanation of a patient's health problem, and the processes for diagnosis are often iterative, not a single event. And it involves from the clinical assessment, history taking, physical examination, several laboratory tests, radiological examinations and diagnosis follow-ups, communicating the results to the patient and families, and patient engagement also in this entire journey of the diagnostic pathway. And it also involves uncertainty, thus leading to unique challenges for patient safety. So what is a diagnostic error? Diagnostic error emerges when a diagnosis is either missed or inappropriately delayed or is wrong, such as a completely misdiagnosis of cancer despite symptoms, or a wrong diagnosis. Patient is told that they have one diagnosis but there is evidence of another, and it may be a delayed diagnosis, that is, abnormal results are suggestive of cancer or some disease but no one has communicated to the patient. So it's a delayed diagnosis which are very critical and can lead to significant harm. A failure to provide a correct and timely explanation to patient health problem or communicate that explanation to the patient also involves a diagnostic error, because it represents several missed opportunities to make a correct or timely diagnosis which is based on evidence. So anything which is missed, which could lead to harm, is a diagnostic error, and it may result from some cognitive factors or from system factors. And the opportunities could be missed by providers, care teams, systems, or the patient. So there are many steps at which the opportunity to correctly diagnose may be missed by different stakeholders. So let's look into a conceptual model which shows the interaction between missed opportunities, patient harm, and no missed opportunity. So missed opportunity means where some action could have taken which could have prevented an error or harm. And so harm could be because of delayed or wrong diagnosis, and there could be no missed opportunity, which is where we could not do anything about it if it was delayed or missed because of, maybe the symptoms were not there or the test was not conclusive. So if you look at the burden of harm, nearly 16% of preventable harm across health systems because of diagnostic errors. And in primary care settings, the Organization for Economic Cooperation and Development, which has about 44 countries, their members, they report that delayed diagnosis is amongst the most common cause of patient harm, particularly in the low and middle income countries. And not only diagnostic errors cause significant patient harm, they also actually hinder the achievement of sustainable development goals, such as not being able to reduce maternal mortality or neonatal mortality or under 5 mortality, also diagnosis of communicable or non-communicable diseases. So several of these important programs, because of wrong misdiagnosis, may be not achieving their targets of sustainable development goals. So that was about diagnostic safety. Few words about the Global Patient Safety Action Plan, because we wanted to use this opportunity as well to show you the global efforts which are going on for patient safety. In 2021, the World Health Assembly adopted a Global Patient Safety Action Plan, which is a roadmap for 10 years of concerted action on patient safety. And it has a 7x5 matrix, so 7 objectives, and then on each of the strategic objectives there are 5 strategies each. So it provides a very systems approach to patient safety. And these are policies for zero patient harm, high reliability systems or high learning organizations and human factors applications, safety of clinical processes at every step, patient family engagement, healthcare worker education, skill and safety, information research and risk management through reporting and learning systems of adverse events, and also synergy partnerships and solidarity with different technical programs. And the action plan also has a very clear vision, a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere, with the mission to drive forward policies and a goal to achieve maximum possible reduction in harm globally. So this is the 7x5 matrix, which has 7 strategic objectives and very concrete strategies under this framework. And so the detailed program, actually the full program and the plan was launched in May 2021. So you will have it available on the website. Now, just few words about the safety of clinical processes and how it interlinks with the diagnostic safety. So this particular strategic objective has 5 strategies, and it addresses the first one, which is safety of risk-prone clinical procedures. So we introduce pathways so that we can reduce the risk. Wherever there is risk-prone procedures, we reduce the risk, and that is diagnostic safety, and the reduction of diagnostic errors actually sits under that particular strategy. And the others, of course, are related to medication safety, IPSC and AMR, and also safety of medical devices, medicines and blood and vaccines, and patient safety in primary care and transitions of care. So with that, I would like to conclude my introduction, and then I will be asking our members to join here. So, as you know, that the World Health Assembly has also established a World Patient Safety Day from 2019, which is dedicated to a theme every year. And this year, for 2024, we have a theme of diagnostic safety. The day is observed every year on 17th of September. And we've got the slogan, which is "Get it right, make it safe." And I invite and request all the members present here to actually utilize this opportunity and take the message of diagnostic safety through observing the day as much as possible. And this is an iconic orange color, which we are using now every 17th of September to light up monuments in orange color. So this is just a scoping, and I would like now my panelists to please join me here. Thank you. So hope it gave you some conceptual, background on diagnostic errors and diagnostic safety. And taking it further through discussion with our panel members, my first question is to Dr. Preetham. What are your views on diagnostic safety? So if you can tell us what are your views on diagnostic safety, and as the title of this panel discussion says, is it so simple really as the topic of this discussion?
Yeah, the title asks, first of all, good evening, and probably the last part of the session, so we'll not make it boring. We'll try to make it as interesting as possible, and we'll try to close it as early as possible so that you can leave. The question, the safety, whether it's simple, it starts from the answer saying that it is complex and it is sensitive. These two things are, very important to understand that. As Madam said, the explanation, the definition when we talk about diagnostic safety, so it is the failure to establish the right and the correct and the timely explanation to the patient ailments or patient health problems. So if you see the statistics globally, though there are many studies are being conducted, but whatever we have the statistics, what is available in the current scenario, but it may be the tip of the iceberg as of now. So the current statistics which says that about 3 million people die out of diagnostic errors, and which is a very, very high number, and India probably contributing to 2/3 of the same. And if you take United States or UK, there are about 80,000 people die of diagnostic errors, and in US about 800,000 people who there are diagnostic errors that are taking place, of which 400,000 deaths and equal number, there's about another 400,000 disabilities that are taking place. So it is a big number that one can have to look into and work towards it. And again, the statistics what talks about is there are certain areas, the low-hanging fruit. If you address that immediately in a targeted approach manner, Like for example, the stroke, the sepsis, the pneumonia, the deep vein thrombosis, and CA lung. That itself contributes to 40% of diagnostic errors. Probably if you just reach out these numbers, then maybe we can, reduce the impact to a great significance in a short span of time. So thank you so much.
Thank you very much, Dr. Preetham. So taking it further, I would like to ask Dr. Malathi, from the clinical perspective, what is your take on diagnostic safety? How important it is when decisions are being made from a clinical point of view?
Thank you very much. The moment we say diagnostic, the most important aspect that comes to the mind of all of us is the person behind who is responsible, we believe, in diagnosing, and that happens to be the clinician. So everything is going to center around this person who we believe is very powerful in terms of rendering care to the patient. So when I talk about diagnostic error, I'm going to talk about it from a clinician's perspective. So the definition was beautifully, I think, given by Madam when she rightly said, what is a diagnostic error? And if you really analyze the definition, it was all about accuracy, timeliness, and communication. These are the three aspects which are considered to be delivery of care. That means the doctor is able to diagnose the condition. Diagnosis is one part of it, but he has to diagnose it accurately, and that's why the rest of the part of it was brought out. So the most important is accuracy in the diagnosis. The second part is the timeliness. Taking a long time to diagnose, you might have lost a lot of time. So the accuracy, but more important and very critical is communicating to the patient. A lot of gray area exists in our country is because of the communication aspect. So all of these three aspects have to be considered when you look at diagnostic. But at the same time, why is it challenging? Why is it not very simple when you have to just deal with a clinician? The reason is the entire diagnostic process is very complex. There are multiple factors which are involved, multiple touch points. It's not just the doctor who decides it. There are other healthcare providers. You have the laboratory, you have the radiology. So many of them contribute for the person to make a diagnosis, and one error in any one of these touch points is going to affect the diagnosis. That's why we say it is complex, it is very dynamic, and third and last but not the least is you are not able to measure it. In all the type of outcomes that you can measure, it's very easy to measure the number of falls. You can easily measure the surgical site infection, hospital acquired infection. How many of us are able to say these are my diagnostic errors? The reason being there is an element of cognition. It is the knowledge factor, and that becomes very difficult to measure. So putting it in a nutshell, it's important for all of us to know in our lifetime, every one of us will have at least one error of diagnosis. This has been proved by the Institute of Medicine report that has come saying every one of us, sometime in our life, there will be a diagnostic error because there is a human factor, and to err is human. And having said all of these points, what I would like to therefore say is, if I have to talk about diagnostic error, which means I need to measure it. And what you can measure is what you can monitor. And what you can monitor, you can improve. Therefore, the starting point is, can I measure diagnostic error? And if I'm able to answer that question as yes, then it becomes simple. But unfortunately, at this point in time, the answer is doubtful, whether I can measure diagnostic errors. And that, therefore, takes us to the greatest of the challenges in actually understanding diagnostic safety. And therefore, I'd like to say that the next step would be probably looking at what can be the challenges. Thank you.
Thank you very much, Dr. Malathi, for elaborating on the clinical perspective for diagnostic safety, particularly the correctness, the timeliness, and the communication aspects of it. So moving further, my question now is to Mr. Dasgupta. How big is the burden of patient harm in your opinion due to diagnostic errors and unsafe diagnostic practices?
Okay, just let me start by some of the experiences that I had personally had. You know, years back, one of my wife's uncle, he was diagnosed with, I think, a non-Hodgkin's myeloma, lymphoma. Sorry, I'm not a clinician, so I sometimes make mistakes. So, non-Hodgkin's lymphoma. Now, he was a diabetic patient, and so the doctor decided to give chemotherapy, but what she said was that, you know, he should give 6 rounds of chemotherapy in 12 cycles because, you know, he was diabetic. So after giving 12 cycles of chemotherapy, you know, there was a lump here which vanished. And then after some time we found that there was a second lump that came under his armpit. And then there was some sort of a, you know, the doctor was a little worried and said that, you know, the slide needs to be re-examined. So when it was re-examined, we found that it was actually a non-Hodgkin's lymphoma instead of a Hodgkin's lymphoma. And by that time, you know, it was too late. And as it is, he was very weak. He had undergone 12 rounds of chemotherapy, and we couldn't save him. So this is an example where, you know, when we diagnose something wrong, it can lead to death. So when you ask me the question, what is the burden or what is the sort of effect that you have due to wrong diagnosis, you know, it could lead to death. Now, the thing is that, you know, of course, it is human to err, but I think what we are missing out is that sometimes, you know, you have doctors who are very senior doctors, you know, clinicians who do the tests and who look at the reports and give the results. Very, very senior people, especially in large hospitals with years of experience. And, you know, but when they are in doubt, you see, I think it becomes an ego problem sometimes that they don't discuss this with their colleagues. So I think it is extremely important that when someone is in doubt, you know, it is always better to call. Maybe for inpatients, we say it's a medical board. But even for diagnostic tests where results are not very clear, I think it is extremely important that doctors get together, put in their minds and come out with a diagnosis. And the doctor who's doing the test should actually have the courage and no ego problems to call others to discuss and give the correct result. So this is one part. The second thing is that, you know, many a times what happens, I've seen that we depend on junior doctors, we depend on technicians to read out the result on phone. And now, you know, you have digital signature, so the doctor may not be present and you release the report. And especially at times where it is off office hours, especially night, maybe on holidays, okay, where doctors are not willing to come to the hospital, right? Even if they are on call. Sometimes you find in the emergency where a scan has to be done, you know, the doctor may just ask someone to do the scan and send the report through PACS instead of personally coming and doing the scan. So I think it's extremely important that we need to ensure from the management that doctors are present 365 days into 24 hours around the clock. Because, you know, treatment doesn't stop at night or on holidays. So that is another point I think that we need to look at. And finally, let me tell you that nowadays, we compare safety. We talk about patient safety. Diagnostic safety is also related to patient safety, and we compare patient safety to airline safety, because airlines have actually, they have gone into safety protocols in such a way that they have one after the other checks and balances, so that if there is one failure, there is another check that is in place. And I think we need to develop that sort of check system in the organization, where if there is one person who fails to diagnose something, there is a second point where the checking is done. Also, if some of you have read a book, there's a book called Why Hospitals Should Fly. It's an excellent book, and it talks about anyone, in the medical fraternity, especially a nurse or someone who's going, every time you go to do a test or going to give medicine or something, you must tell yourself that, there is always a chance of 50%, there's a 50% chance that I'm going to make a mistake. So I must make sure that, that I check and recheck before I give the final result. Thank you.
Thank you so much. Particularly in this case, it was not only a wrong diagnosis, but delayed diagnosis as well, which led to the death of the patient and fatal outcome. And diagnostic errors, of course, have major impact and cause a significant patient harm. Moving on to the next question, which is linked to what Dr. Malati mentioned about the need for measurement. So, what do you think are the challenges in measuring diagnostic safety?
As I mentioned last time, a lot of us focus on outcomes. It's common that all of us have KPIs and a large number of them. And it sometimes becomes even a burden to them, because these have become mandatory sometimes. Some are required for accreditation purposes. Some are required because the hospital would like to have it. And it is a burden. It's good to measure all of them. But if you really focus and we look at it and say that these are process, these are structures, and these are outcomes. Most of us are very, very familiar with these KPIs, which is based upon these three themes. Most of them, if you look at from a clinical perspective, when we talk about diagnostic, it's all about clinician and clinical. How many of us actually measure the diagnosis part of it? We measure the outcome. We always say the time taken in a stroke patient for imaging. You say the door to balloon time, so on and so forth. We measure each one of them. But very important for us to remember that these are outcomes. But what about the diagnosis component of it? And in the diagnosis, I reiterate the three principles happen to be accuracy, timeliness, communication. If I can measure these three, it would mean a great way of measuring the actual diagnostic errors. Out of this, some amount of communication is done through assessments. We do a lot of assessment is possible. How many of us measure communication related to diagnosis? The communication is just about did you assess the patient is what we find out, but what was it related to diagnosis is not measurable. But let me come to accuracy. Now, accuracy is very, very difficult because again, it depends upon the domain expert. And the clinician always, like rightly brought out by Mr. Rana to say, would you be able to ask the clinician and question about this? Because it all depends upon the domain expertise. It's a cognitive aspect which is difficult to measure. What we do is what is obvious. We just find out, some of them are very obvious. A patient coming with a chest pain to the ER, you tell them that you're fine, maybe it looks like it's something to do with gastritis, prescribe an antacid, the patient goes home, and within 72 hours, early morning, comes back to the ER with a chest pain because you failed even to do an ECG. This is very obvious because what do? We measure return to the ER in 72 hours. You can capture that. And then you say, why did the patient go out? And then you say there was an error in the diagnosis. This is obvious, which we still do. A large number of all our hospitals do measure obvious errors. But what about the one which is not obvious? many of them, they escape our sight because they are not easily identifiable as actual errors. And that is where I want to bring out the fact that how do we do the diagnosis? Do we say acute coronary syndrome, or someone writes it as myocardial infarction, someone puts it as chest pain? So there is no standardization of the diagnosis. The terminology itself is so difficult to find out that it is difficult to measure as well as to audit it. That is why non-obvious diagnostic errors are difficult to make out. That is very, very important. When I come to now the second part, timeliness. How do you measure it? How quickly did the doctor diagnose? Is there a template which says you will diagnose asthma in 7 visits? You can diagnose this condition in 4 visits. Impossible. Because it all depends upon the presenting symptoms of the patient. Sometimes the doctor might take more visits because he wants additional tests to be performed and says, let me get the results, and tells the patient, I'll let you know because I need these tests. So would you say that there is delay in the diagnosis? Again, a question mark. So there is no standardization available to see this should be the number of visits. We only go by what is available so far in the legacy, in the history, and say by and large it should have been done, but that becomes a questionable aspect of it. And therefore, friends, timeliness, accuracy is important, but I would like to add a note, it is efficiency. It matters to the patient, the cost factor. You cannot go ahead with any number of investigations and then say, unless I do the battery of 20 of them, I can't diagnose you. And therefore, at the end of the day, it is value-based care. It is all about cost. It depends upon the benefit. It is the risk. Every one of them adds to it, and then only you can establish a diagnostic entity. And that is why it becomes very, very complex. And now they are working out, and probably when I talk at a later time on the results and the evaluation, it becomes very clear to us how can you evaluate. And one of the best systems that all the hospitals now are relying on is your electronic medical records. The way to diagnose an error to a large extent, provided your doctors are documenting well, you can diagnose. You can look through your EMR and find out, was a diagnosis missed? Very well brought out by Madam in the beginning. Is it been missed? You go through the symptoms and signs, and then you go through the electronic record by an audit, and then you say, how was this diagnosis missed out? It is very clear signs and symptoms. So you can identify a missed diagnosis. You can identify a wrong diagnosis. We do what is called as a pre and post-operative diagnosis. It tells you a lot of information on the diagnosis. So some of these, through the electronic records, has played a role in us in diagnosing errors. But we have a long way, no doubt, to go. But it doesn't mean that there is no future. If we are able to have good documentation, we will be able to detect diagnostic errors and put in corrective steps. Thank you.
Thank you very much, Dr. Malathi. Patient safety measurements are absolutely vital for any improvement initiatives, and you elaborated on that. If we cannot measure, we cannot monitor, and we cannot improve. So extremely important to find indicators and measures for diagnostic safety as well. So linked with that is my question to Dr. Preetham. Are the diagnostic errors preventable? And could you share any initiative which you have come across on diagnostic safety in your organization or in the region?
Yeah. Just to start with the thing, what Mr. Rana has said, that he talked about the plane story. How many of you are aware that what happens if the 2 engines go off of the plane when it's flying?
It's flying.
Yeah.
The thrust is lost.
Yeah.
So they have to glide it for landing.
Yeah.
Thrust is lost. So they'll lose altitude.
They lose altitude, but can they land safe?
Yes, it is possible to land safe, provided they keep the nose up and search for a safe landing.
Okay, yeah, that's true. The design, the workup that has been done on a plane, it is, we talk about 4 sigma, 5 sigma, 6 sigma. See, they work at the sigma 8 sigma level, and that is a level of precision that what they are looking into. And even if both the engine goes off, like first level failure, second level failure, third level failure, even that happens, a plane can land safely. It is designed in such a manner at 8 sigma level that it can go and land, provided you have the surface, which is smooth, and plane can land, of course. So there are incidents that has happened wherein plane has landed, even both the engines have failed. So that is the level, that we are looking at the preventable aspect in healthcare. So if you look at healthcare, probably it won't be even at 3 sigma level as of now. So that is what we need to think on. This is a time to think on. This is a very niche area where we have to start looking into the preventable aspects in the healthcare area, because we are in the rat race of treatment and the P&L and things like that. Very, very, very few people look into that preventable aspects in all these areas. So as Madam asked, is it preventable? Yes, the diagnostic errors, if you look into, again in a hospital is very complex. But if it is again, if you look at the clinician point of view, many things are cognitive factors related. If you take up the percentage point of view, 75% of the diagnostic errors are happening because of cognitive factors. Only 25 is the rest of the things. So when it becomes cognitive factors, then of course, is it trainable? Yes, you can train. Is it targeted training? Yes. You can't give a generalized training, because when you start giving a generalized training to a particular thing, it goes in the air. So we need to give a targeted approach. We need to have a targeted approach. We need to give a targeted training. And we also, as I said earlier, it is already we have identified certain ailments that are, which is a low hanging fruit, wherein when we intervene, we can get the maximum result out of it. So if we approach even those few ailments, the results will be huge, and it is preventable. So again, targeted approach. In the targeted approach, cognitive factors. So in the cognitive factors, again, certain ailments that need to be looked into, and it is preventable. And by and large, if you see again statistics point of view, 80% of the diagnostic errors are preventable. So that is the amount that what we are looking into it. So with that in mind, I'll just close my part of it. So it's a time for us to wake up and look into these factors, where how we can do these approaches in our respective areas, and try to bring in small changes which will give a maximum impact. Thank you so much.
Thank you very much indeed. So linked with that is mention about the challenge of diagnostic safety. How do we reduce diagnostic errors? So my question to Mr. Dasgupta is, what are the different strategies to enhance diagnostic safety?
Okay. Ma'am, that I would carry on from what Madam has said is sometimes, delayed diagnostic results result in, bad results. So nowadays, what I feel that, the trust factor between a doctor and the patient has really reduced. You see, previously what used to happen is the doctor and there was a trust factor between the family, the patient and the doctor. And we also said that, we also thought that there was some sort of a clinical eye that a doctor had. So, the diagnosis of a particular disease maybe was done much faster, because there were fewer tests that were given to a patient to actually diagnose the result. But now, with so many medico-legal cases coming up, and the trust factor between patients and doctors going off, and you having Google and internet and so many Google doctors coming in, the doctors will give a battery of tests before he will take a final decision. And that also delays, I think, the start of treatment of a patient. Now, one of the things that we are looking at in our hospital group is that when a patient comes into the hospital, the nursing assessment and the doctor's assessment should be completed within the first 2 hours. Now, if that happens, then whatever tests are recommended, the samples must be collected and immediately sent to the lab. We look at the turnaround time for results so that we get the results quickly and the treatment can start quickly without reducing, wasting, a day. So even that helps in reducing the loss of a patient in the hospital, which indirectly helps in reducing the cost and also prevents hospital-acquired infection. So I think, that is one part that I want to speak about. Now, if we are looking at reducing, diagnostic errors and what is the strategy for reducing diagnostic errors, there are a few things that come to my mind. One, of course, is very important is patient education. It is very, very important that patients and their relatives are given, information about the sort of tests that are going to be carried out, what may be the expected outcome, and and what is the test all about. So patient and their relatives should be well educated regarding the diagnostic tests. That is one. Secondly, the patient's or their relatives' participation in deciding, the mode of treatment or the test that needs to be done also is necessary. So, so they need to become a part of the treatment team, they need to give their decision on what they expect or what they would like. Many times we do certain things without even informing the patient. Third thing, which is very important, is having a culture of safety in your organization. Staff or even junior people, they must have the authority to bring out lapses that are happening in the in clinical field or any other field. They should that sense of openness to actually spill out the bean or be a whistleblower to wrong practices that are happening or shortcuts that are being taking place in the diagnostic field is extremely important. And we need to ensure that we will not take punitive action, or there should be no biasness on even junior doctors or associate consultants who actually bring out these shortcuts that may happen. So incident reporting becomes very, very important. And doing an RCA for those incidents and find out why it has happened and what is the solution to it, how can it be reduced, is something that we need to look at. These are things, I think, which will reduce the chances of error in diagnostic results. Many a times we have seen that when the volumes are very large, we have seen doctors signing reports without even looking at it. You see, they depend on the senior technicians, and once the technicians give them the report, they just keep on signing, and it happens in all big hospitals without even going through the report properly. They sign the reports, and so I think that these are things that need to stop. And these can only stop when there is a sort of awareness among the others, and they spill the beans. I'll give you a small example again, coming back. this book which I was mentioning, why hospitals should fly. There is an incident where, there's a Lufthansa flight. It's a 747 Boeing carrying around 500 passengers or so. It was, the flight was, there was a flight which was supposed to land at Heathrow Airport. Now, because of bomb scare over there, it got diverted to a smaller airport, right? Now, the commander of the flight was one of the best known pilots in USA at that time. And while it landed in that small airport, he decided to refuel, which the others, there were two other, the first engineer and the second in command, they were there, and they felt that it was a wrong thing to do because it would take a long time to refuel, and it was not necessary. Now, when the bomb threat was clear, the weather was also extremely bad, and the commander suddenly realized that time was running out. Because I think the rule is that, you cannot fly more than 12 hours at a stretch. So if it becomes more than 12 hours, then you'll have to stay 24 hours or take rest for 24 hours in that particular place. So now he was in a hurry to, get back. So, the ATC, the air traffic control, usually gives the go-ahead in 3 stages. Okay, the first stage, the second stage, and then the third stage where they go full throttle and take off. Now, so this pilot was in a hurry, and by the time the first go-ahead was given, he was already, speeding. By the time the second go-ahead was given, he was already full throttle. And suddenly from the air traffic control, they asked him to stop because there was a second aircraft that was on the runway. But it was too late, and there was a crash and several people lost their lives. Now, what do we learn from this? You see, the 2 people who were there with the pilot, the pilot was so dominating, and his image was so, his personality was so big, that in spite of knowing that they were making a mistake, they did not have the courage to speak out. This is what we are coming to, that even, if your surgeons or your doctors or your, star doctors are making mistakes or doing something which is not right, the younger, the juniors, they need to speak out, and we need to support them. So I think these are strategies that we should work on to reduce diagnostic failures.
Wonderful. Thank you so much indeed for elaborating the need for safety culture and removing the hierarchical barriers for safety with an example which was of course led to tragedy, but it's a beautiful example of how one should work in team and remove the hierarchical barriers for improving patient safety. So in the interest of time, let's move ahead and the third round of questions to our panelists. We've touched upon, the burden of harm and the strategies in the diagnostic safety area. But do you think, Dr. Preetham, there's a difference in the burden of harm or even strategies in the outpatient and inpatient scenarios?
See, as we have discussed that healthcare is a very complex structure and again a very sensitive structure. So there are different locations, different areas in a hospital functioning. You have an outpatient area, you have an inpatient area. Among outpatient area, you have again ER or ED emergency area and the OPD areas. And then of course in the inpatient there are procedure areas like operation theaters, inpatient bed areas. So there are different locations which even critical beds, critical areas. So different areas work in a different function, in a different pattern. So there have been studies, but not exhaustive. A lot more to understand on these aspects. So if you see as of now in the current scenario, number of errors that are happening in the outpatient areas versus inpatient area, outpatient area surpasses the inpatient areas, wherein inpatient areas contribute about 17% and the rest of the areas, this I'm taking the statistics that is available. However, it might be again a tip of the iceberg, so it might change sooner or later. So outpatient areas are carrying the major burden of having the errors. The possible causes could be because in outpatient area you don't have that much of a time to spend with the patients, to understand the patients, and to put across more questions to ask or to listen to from the patients or their near and dear ones. So even most of the trauma centers, ED, emergency area in any specialty hospitals, the flow is so high that you hardly get any time to look into the matter in depth. So chances of errors are much higher when compared to IP areas, where in inpatient you have certain time, you can take a call, you have a team of doctors, seniors, juniors, and around the clock there will be someone. So there is discussion that are taking place. So the errors might be less compared to outpatient areas. And also a lot of studies that are being carried out in the emergency areas because ED is again a focus area as far as diagnostic errors are concerned. So many studies have been carried out, and it has been found that this is the reason which I'm talking about was the causative factors. So many institutions have brought in many changes in their system, wherein this aspect cannot be mitigated, it can be minimized. So that's my viewpoint between inpatient services and the outpatient services. Thank you.
Thank you so much indeed. So, Mr. Rana mentioned about one of the key strategies for enhancing diagnostic safety is patient engagement. I would like to ask Dr. Marathi, what do you think is the diagnostic safety from patient perspective?
Yeah, the diagnosis as I mentioned earlier, is centered around that one person who happens to be the clinician. But at the same time, this diagnosis and the delivery of care, the receiver happens to be the patient. So now I'd like to tell you from a patient's perspective, what is the role of a patient to reduce diagnostic error? How can a patient help? The only way the patient can help is if the patient is a part of the entire care mechanism. What do we mean by that? It simply means how much time and energy is invested in a clinician to explain to the patient that this is the care that I am going to provide, and also asking from the patient what would they think about the care that is to be given. And that is what we call as participative decision making. It is no longer like in the earlier days where the doctor just says, this is what I'm going to do, this is for surgery, get admitted tomorrow and I'm going to operate on you. Now the patient asks, is this the right line of treatment that you want? Is there an alternative line? Is there a medication management? Can I go for a surgery at a later date? And he or she is very well informed. Therefore, it becomes, why is it important from a care perspective? If the patient knows the details, he or she will definitely know when something is going wrong. And that is the first part. That is why we say patient should be a part of the care mechanism and should know to identify if there is a problem. And the first thing to tell a patient is safety is your responsibility too. It is not only the responsibility of the provider or the healthcare organization. The patient himself has to be responsible for the safety. And therefore, the doctor starts by communicating, saying that during the course of treatment, if you do come across any one of these problems, please notify. Please let the nurse know. What is the importance of that? It avoids any error that is happening. To give a simple example, was a mother in one of my own hospitals when the nurse was about to administer this and said, I'll be giving this IV. The mother was very familiar because she knew what is a medication to be given, very well explained by the doctor, and clearly told that there will be no IV injections being given to her. So the first thing, she stopped the nurse and and she said, but I'm very clearly told that there is no IV injection. How come you're giving me the IV injection? Please let me know the details. And suddenly the nurse realized it is for the patient in the next bed. If this was not told to the mother and she would have just accepted, it would have caused a great catastrophe. So that is an example of where a simple education, communication, knowledge to the patient itself is responsible for safe care. And having said that, it means what are the simple ways that you can do it in a hospital? So carrying it from what Mr. Rana had to talk about it, the simple strategy, when on rounds, make sure that whatever you are going to talk to the patient is loudly said in a language that is understood by the patient, and it is told to the resident doctor who is there on the rounds, so patient knows exactly what is to be expected from the nurse and from the doctor. The moment you simply come, write it or scribble and you walk out, patient is not aware what is the treatment that I'm supposed to get. Therefore, simple one, in every rounds, it is very, very imperative that the doctor speaks, communicates, and in the language, not using medical terms. I've been as a medical director for over 3 decades, and many of the complaints are, I did not know what I was supposed to go through. I didn't know that this has to be done. So it's an expectation management, and therefore it is safe to the hospital because the patient will guide you as to what can go wrong. So that is a very, very good example. One of the things that has come up now is it's an organizational priority, and this is where I take from Mr. Rana, who says culture of safety. It is a top-down, just like quality is top-down, safety culture has to be a top-down approach. And very, very important, we now have totally focused not on the regular outcome indicators. It has to be patient-reported outcome measures, which is called as PROM. All hospitals across, it is now being made mandatory that the patient has to report your outcome. It is not that you say that I did this particular door to image time within 1 hour, but if the patient still continues to be sick, he or she has a right, and that is called as patient reporting. The outcome measures is a measure of your diagnostic capabilities, and therefore the most important take-home point at this point is that the patient has to be a part of your treatment process, ensuring safety, and therefore we call it as a safety culture from a patient's perspective, and that immediately brings down your own errors because it will prevent any amount of treatment which is not in line, which is anticipated. Thank you.
Thank you, Dr. Malati. So in the interest of time, we'll go to the final question, which is related to technology. So how would you, Mr. Rana, how would you induct new technology while ensuring diagnostic safety?
See, I think one of the things that we do, this is what we do every year, because you need to bring in new technology, you need to upgrade existing technology, and you need to phase out old technology. And this is for better outcomes of the patient. So when we look at new technology, the first thing is we look at what is required by the community around, what is their requirement. We also look at, what the hospital is looking at, say, 2 years, 3 years from now. Say, for example, robotic surgery is something now that has picked up. Or, proton therapy, which Chairman thought of a few years back when no one even thought of proton therapy, and he invested 1,200 crores getting the proton, and today it is something that has really picked up. So I think we need to have a vision as to where we want to go. We need to look at the community, what is their requirement. The other thing that we need to look at is, the technology that we are getting, how safe is the technology? That is one. Whether we have the correct clinical staff to use that technology, whether we have the technicians who would be able to use that technology, and if not, what is the sort of training that is available for the clinicians and the staff before we bring in that new technology. also, what is extremely important is the new technology that we are bringing in. What sort of after-sales service are we going to get? What is going to be, what are the spare parts that are available with them within the country, so that the downtime of that machine or new technology that is being brought in is minimized. So, and of course, whatever we bring in, it is the consultants we discuss. It is the consultants who lead from the front, and we work around the consultants, because at the end of the day, the consultants are going to use that technology. So this is something we allow our consultants to take a decision. They come to us and tell us that this is the new technology that I would require, and and then we work around with them. Even the sort of any technology will have different levels. So what is the sort of whether they want the absolute cutting edge technology that is available, the top thing, we depend on them. And of course we also need to look at our revenue, our finances that are available, and prioritize which should come first and which should come second. Thank you.
Thank you very much indeed. So in the last 1 hour, we've actually looked at from various perspectives, various angles, the issue of diagnostic safety. And if you reflect on the topic of this panel discussion, is it so simple? Diagnostic safety actually is not simple. It is complex, but it is still achievable with concerted actions of all stakeholders. The considerable effort has been done globally, a lot of investment in diagnostic safety. However, significant need is there for comprehensive action by different stakeholders to ensure that we have implement the strategies which were elaborated beautifully for enhancing diagnostic safety and reducing diagnostic errors. Diagnostic safety actually intersects with entire spectrum of healthcare delivery, from the granular interaction between a clinician and a patient, to at the global level on policy directions to ensure diagnostic safety. And with World Patient Safety Day this year, we really hope that such type of sessions will actually be taking place across the world, which will provide, and I really believe that this session today will provide a sort of platform as a catalyst for continuing dialogue and also for application of this shared knowledge in the area of diagnostic safety. Because we really need to address the area of diagnostic safety to achieve patient safety. And with that, I would like to thank all our esteemed panelists for excellent, input and contributions, as well as there's no time for questions, unfortunately, but we'll be very happy to take questions if you can send it to us by email, and I will ask our organizers if they can send an email and give an email address where questions could be sent on this session.
We can have the questions now.
Do you have time for that?
1 or 2 questions.
Okay, great. So any questions on any of the perspectives or aspects from where we looked at diagnostic safety issues?
As Dr. Malvi was talking about 3 components which are very, very important in terms of communication, timeliness and accuracy. Can AI have any role into it in terms of accuracy to prevent error?
Thank you. Thank you. You asked for that question. I was planning that should come along with the technology. Yes, AI is a tool which is being used now in many of the hospitals. The most important part that has to be remembered is the brain behind is still the clinician. But what it can do, definitely it can augment the errors becoming much lesser, and you find that there would be an idea to be given to for the clinician to think on an evidence-based practices, because these are fed already in the AI tool. So it prompts and tells the clinician with these symptoms and what you have got into the medical records, this could be probably to be thought of as the diagnosis. So errors numbers can definitely come down, though it may not replace completely because of the fact that all of us know. But then yes, there are a lot of software which has come up which in what is known as the clinical support decision-making software. It has also helped particularly in the field of laboratory, because they are able to cut down the time, and AI tools have been used for diagnosing cancer. So that has definitely definitely improved. And one of the things that has been done is particularly in the field of colorectal cancers. The way they have tried to look at is the ratio on the number of cases that have been diagnosed in time. And they have found that with the use of this tool, the diagnosis has been much more clearer, rapid, which means if there are red flags, you can immediately diagnose rather than waiting for several months and you lose the window of opportunity. So this has shown scientifically, they've done a lot of work in the field of malignancy, and it has helped phenomenally in improving the care. Thank you.
Thank you very much. Any other question?
I have a suggestion to make and a comment also. I think one aspect which I request Dr. Malti Madam to comment on, usually the radiological diagnosis, because with the number of centers coming up and so much of telereporting happening, I find that the error numbers are alarmingly high. In fact, I am also facing that problem for my because I have only one radiologist, so I have to bank on a teleradiology healthcare. I was heading a foundation, I had 10 cancer hospitals, there I had no radiologist. So I was totally banking on a teleradiology system. I think there is a need for the clinicians also to write the clinical notes appropriately and what are they expecting out of the radiology. And I think over a period of I think that it has become more and more scriptic, and in some cases it has become so scripted that they simply write some abbreviated word and that's what it leaves. So I think, Madam, would you like to comment on this?
Thank you once again for the question, and very, very well said. A lot of the support diagnosis does depend upon the person who is asking for the test. And therefore, the one point that I brought about electronic medical records, which have to be as accurate as possible, and that should help. Now, there have been tools which have been used, and we have tied out a tool which has served most of the purposes, sir. In here, the doctor does not have to write at all. It is a voice to text. And we have tried number of them. So initially we had a problem because it depends also on your accent of talking. A person who is from the different states, when they speak, the particular one was not able to recognize. But now they have improvised it so well that in any accent that you speak, it is able to give it to you directly into the text. That is number one. Number two, it is also AI enabled, which we have just got it a month back. And this AI enabled tool is, even if you try to talk something, as long as you put your clinic and the doctor says this is the clinical complaint, the AI tool judges what should be the right wording to be put into that and converts it. You can also say translate. So you can speak in a language that you are comfortable with. A person, say in Kerala, finds it very comfortable to talk in Malayalam, it will automatically translate it into the English language, and a lot of validation has been done. So it is some amount of improvisation which will help for people to simply have a voice to text, because doctors, one thing is there, I've always said that we should do a research on all students in the 10th standard. Students who have a bad handwriting are very likely to become doctors. So this is the way I look at the way that everybody has got an illegible writing. But having said that, if they speak and you can convert it, a lot of such errors can definitely come down. So that is the way forward, and it has really made a difference on the speed with which you can do that.
And we are using it in Kolkata.
Yeah, so in many places it has come, and the good part of it is getting improvised more and more. Earlier it was the dragon system, and accent was a big issue. The doctor would say something and what would come out of it were more errors than if it was written. But now it's become very smart, it's very intelligent, and it is able to do any language that you want. And one of the most recent one on clinical documentation, it is a software where the doctor speaks. Now, it is so tuned that someone comes in between. Suppose another person walks in and says, "Hello doctor, how are you?" It automatically does not record that. It records, it puts into it, and then it says submit. It goes to your HIS. it will put into clinical complaints on examination and omits all the unwanted. It is able to recognize this particular talk has nothing to do with the patient at all. So that intelligent it has come out, and it has really worked because it is just that it sits on the HIS of the hospital. And then the moment you put submit, you don't have to do anything. It puts it into those baskets, puts the diagnosis. You just have to approve that you're fine with it. So I think these are all very good improvisations, making errors as much less as possible. But I don't know, it's a long way to say a zero error. We can only say reduce harm to a patient. Thank you.
Thank you very much, Dr. Malti, for a very pertinent answer, particularly to utilizing technology and how it's improving over time. But addressing the issue of human fallibility in particular, wherever there are processes where human errors can lead to harm, that is where technology, if appropriately applied, can significantly reduce the risk of harm. So any other questions, please? So I don't see any hands. Yes, please. Would you like to say?
No, we are calling us for...
We are asked to close the session for a photo session.
All right. Okay. Thank you very much indeed, and really appreciate your deep interest, and also extremely grateful to our panelists for elaborating on the issue of diagnostic safety in such an eloquent way that it has really opened up several ideas and suggestions for improvement, and I really hope that you can take forward the message of diagnostic safety, particularly this year with Work Patient Safety Day dedicated to diagnostic safety, so that we are on a journey to reduce harm to patients due to diagnostic errors. Thank you so much indeed.
Next up, we'll be having the paper presentations. So it is in this hall and the adjacent hall as well.
अच्छा ठीक है मैं जा रहा
First, we'll take a photograph. Come. Come, sir. Sir, आप मिडिल में आ जाइए, सर. Come.
I just completed your Shamsi document. Call number 4, right?
Just look forward.
Okay, ready, everyone smile. Just come here. Come on, okay. Okay.
What's your name?
Thank you.
Oh, thank you.
Go and give a photo, sir. सर अपना पैनलिस्ट का फोटोग्राफ सर मैं इधर ही है सर हिबिस्कस मेरा कौन सा हॉल नहीं विल टेक दी फोटोग्राफ इन कम बैक दे हैव कॉल्ड ऑल द पैनलिस्ट अच्छा ठीक है सर
आई विल वेट फॉर यू सर हिबिस्कस वन
आ जाएगा
Ini
क्या ಕಾಣಿಸುತ್ತೆ
Good evening, everyone. So we'll be starting with the paper presentations. So may I call upon our moderators, Mr. Abhilash Pillai. He is unit head of Apollo Hospitals, Indore. Abhilash is a senior healthcare leader with over 20 years of experience, spread across locations in India and Middle East. He's currently his current role is as a unit leadership. He oversees the Indore operations spread across 2 hospital facilities and is leading the group expansion aspirations in the geography. Prior to this Indore stint, Abhilash was part of group Middle East operations based out of Oman, where the group runs a chain of hospitals and clinics. Abhilash was part of the founding team and played a pivotal role in the expansion of group chronic disease management initiatives, which forms a critical framework of leading chronic disease initiatives with sugars, Apollo clinics for diabetes, and is passionate about the possibilities of how the understanding and application of ancient Indian wisdom can help us solve our modern day problems in healthcare and overall. Postgraduate in general management, Abhilash pursued his advanced management program that augmented his training in leadership with BCG Leadership Institute, and is also part of the Apollo Young Leaders program, a batch currently underway at the Indian School of Business Administration. Welcome, Abhilash. Next up, we have Mr. Ajit Jha. He is the unit head of Apollo Hospital, Nashik. He is a hotelier turned hospital administrator, having exposure both in Europe and Asia. Have a proven track record of running successful business operations and human resources that nurture and grow the business. Both cost while at the same time maximizing profits. Possessing the experience and initiative to further bolster an organizational reputation and commercial success. Welcome to both our moderators. So we'll start with our first session. I hope we all know the ground rules. You will be having only 5 to 6 minutes for presentation. The next 2 minutes will be for questions, if any. First up, we'll have the paper title is Marriott Hospital Flood Disaster Lessons Learned and Promoting Patient Safety Culture. The author is Dr. Mohammad Farhan. Please.
So good evening everyone present here. I am Dr. Mohammad Farhan, currently pursuing Masters in Hospital Administration, first year in the Sankara Netradi Academy. I did my undergraduation in dentistry in Thai Mugambika Dental College. So I'm going to present a paper called Marriott Hospital Flood Disaster Lessons Learned and Promoting Patient Safety Culture. This is actually my organizational behavior presentation, which is my first presentation in the college, and my HOD suggested why not send it for this international conference, and it got selected. So a brief incident of what happened in 2015. My city, Chennai, experienced heavy rainfall, and there was approximately 60% of the city faced power suspensions. Cessation of operation in several hospitals was seen, and the major newspaper Hindu also did not publish their newspaper. Chennai airport was closed, and particularly Marriott Hospital witnessed this unfortunate demise of 18 patients due to failures in power and oxygen supplies. So 98 people from the Chennai district were reported to have died. So what are the key events that happened in Marriott Hospital? Is like the hospital faced severe flooding because it's located in Manapakkam, which is an area located near the Adyar River. So hospital sent out a SOS message, and it was indicating some operational challenges and patient admission issues. All this have reported from different newspapers and sources available on the net. So relatives reportedly faced difficulties in admission procedures. There was lack of transparency in emergency situations, and government response and media outcry also was seen. So the methodology which I applied, which I already said, I went through a lot of newspaper articles, including the Times of India, the Hindustan Times, the Wikipedia page, also Mint and Live Law also, for getting suggestion of what exactly happened and what were the suggestions that came out. So what are the learnings from this incident we get? So proactive emergency preparedness should be there. Discussion on importance of hospital proactively preparing for natural disaster should be there. There should be regular emphasis on regular drills, simulations, infrastructure resilience, and to ensure readiness during emergencies. And there should be transparent communication, like examination of role of open, transparent communication in crisis situations, highlighting the necessity of informing patient families about the situations properly, so that there's no dispute between the media, the patient's version, the hospital version, and everything. And ethical admission practices should be there, especially during this time, and government and healthcare collaboration should be seen. So what I have applied is that I have applied all the learning theories which we basically study in organizational behavior. So how can we adapt this? First is the classical conditioning theory given by Ivan Pavlov. So implementing the regular emergency response, like drills can, hospital staff can act efficiently during crisis, like repetitive training. Classical conditioning example we have seen with a dog. Most of us know the story, like during a bell rings and the dog comes and eats. So similarly we can apply it to the hospital staff. Repetitive training can create automatic conditioned response to specific situations, improving overall preparedness. Then there's operation conditioning theory, it was given by B.F. Skinner. So its application is like establishing a reward system for staff who actively contribute to the culture of transparency and patient-centric care can have positive behaviors. Like in the reward the staff who continuously work for the improvement of the hospital. So and there is social learning theory and cognitive learning theory. Social learning theory, like introducing a mentorship program where experienced staff can guide the newcomers how to handle situations, and especially during these emergency services like an earthquake, a flood, everything. So learning from experience of others can enhance overall team competency in crisis management. And cognitive theory, like utilizing cognitive learning strategies such as providing comprehensive training materials to staff for understanding the emergency protocols can also foster to more better innovations. So these are my references, and thank you.
Questions? So how did you calculate the same information in your institute? You have done so good work. How do you calculate it to between your colleagues?
Like I explained the situation, I analyzed the situation in 2015. I was someone was very much affected in the past, so I was reading a lot of articles what happened during 2015. So when I chose, and I diverted from dentistry and chose to go towards hospital administration, I thought sort of a lot of incidents that happened in India, and this incident happening in my city, Chennai, totally influenced me that I should do a study and publish an article somehow on this. So I tried to present. This was my first OB presentation actually. So I came till here and I feel proud of myself. I came till here.
How are you going to further augment this?
I have to better the article, obviously, so to publish in a reputed journals, because this was just an OB presentation and I just applied and I got selected, and it was just a short book. Just an abstract of.
So good evening, I'm Dr. Avinash. I'm the Assistant Medical Superintendent at Sri Shankara Cancer Hospital. This is a practical QA quality improvement project we took up for NABH. This was a proactive risk mitigation project where we looked at what are the possible failures which can happen in supply of medical oxygen to the patients. So the study was to analyze the possible failures and risks associated with delivery of medical oxygen. We adopted the failure mode effect analysis methodology. So the presentation contains introduction, methods, results, and discussion. So not to reiterate that medical oxygen is a basic gas which is without which the patient's medical treatment will be detrimental. So we did a literature review. This is a brief of the literature review. The project at glance, sir, this is a very important slide. The project at glance is that we mapped the whole medical oxygen delivery process, and we found out using the flow chart and the engineering diagrams, and we used the FMEA methodology to prioritize the risks. We listed the risks, we listed 23 risks, we prioritized these risks, and we found out there were 5 high magnitude risks which could cause detrimental supply in oxygen in our institution, and we neutralized those risks using 2 Pokayov solutions, 1 staff training solution and 1 engineering solution. With that, we could reduce the risk up to 68%. So this also involved some capex investment. We spent around 3.5 lakhs in upgrading our facility and making it more safer. So the objectives were to map the oxygen supply dynamics, identify all the possible failures, to analyze what are the possible risks involved, and to neutralize the risks and to sustain the same. That's the most difficult part. So the first is to map. For mapping, we used all these engineering diagrams, vendor analysis, reorder levels, all these reports were used. this is our liquid oxygen plant. So we have both a liquid oxygen plant as well as a gaseous oxygen, but primarily we are liquid oxygen plant, and it is a 30,000 liter capacity, out of which 10,000 liters is the maximum to up to which it is filled, and 2,000 liters is the reorder level, and there is a very robust reorder level where the company monitors it remotely, and then they themselves bring in and refill it. So there hardly any chance of going wrong there. This is our manifold room, and it contains the D-type gaseous oxygen cylinders, which are the backup cylinders, and there are the portable cylinders in the clinical areas, which are the B-type and A-type oxygen cylinders. A-type is in the OT and B-type is in the clinical areas. So this was the total mapping of the process we did, and this from liquid oxygen to the patient care areas. We completely mapped the process, and we found out that these were the defects we found out. So there was no visual identification of the control valves. So where the control valves are not identified. Surprisingly, we found out that the liquid medical oxygen supply system did not have a centralized alarm. Audiovisual alarm was not available in the manifold room. So that will lead to difficulty in identification of pressure defects in the liquid oxygen. And there were no directional signages in which direction the gas was flowing. And we have peripheral oxygen alarms in all clinical areas to detect peripheral control valves also. And the portable oxygen cylinders, which are the B-type oxygen cylinders, for opening them and to use them, we needed a spanner tool, and these spanner tools were regularly misplaced. So we had one more problem on our hand, and there were no security cameras in the manifold room. So our objective was to identify, and we identified all this during our patient safety rounds. So we mapped 6 processes, and we found out 15 critical points across clinical identification, liquid medical oxygen, manifold, central oxygen, and portable oxygen. All areas we mapped, and we found out 15 critical problems to be solved. So these were the. So we use the FMEA methodology, and we use the risk priority numbering, RPN numbering, and we found out that there were 23 areas we need to focus on, but we could not focus on all the 23. So we used the Pareto principle. So with the Pareto principle, we could differentiate clearly between the trivial many and the vital few. And as you can see, 5 significant risks were the vital few we decided to focus on. And how did we neutralize these 5 risks? We utilized very simple solutions. First was we installed a modern central manifold alarm system, which can detect both the liquid oxygen and the gaseous oxygen. We used a chain to lock the spanner tool to the cylinder so that it is never misplaced. We made a direct connection of the peripheral oxygen alarm system so that nobody can switch it off. We did a direct connection, and we used a staff training solution and focused on Muse scoring and vitals monitoring so that the nurses can pick up the oxygen requirement of the patient early. With this, we could reduce the risk with 2 POCA solutions, with 1 staff training and 1 engineering solution, we could overall reduce the risk from 1830, which was our pre-intervention RPN, 68% to 595. 68% we could reduce. And you can see all the spikes there, blue spikes which were causing the problem, have been flattened out. And these are some before and after pictures what we have. So we installed the signages. We installed the new alarm system. This was the old alarm which was not able to detect the liquid oxygen. This is the signages once more, what was not there. Yes. And this was the direct connection we gave, sir. So we made a direct connection so that nobody can switch off the peripheral alarms. And this was the chaining, the chain which we changed the spanner tool so that it's never misplaced. So with some small things we could reduce 68% errors. So I'll end my presentation, my time is over. So I'll end my presentation with this. Thank you so much, sir. Yes. Yes, sir. So we are focusing more on training. So we are now looking at posting 1 engineer 24/7 in the manifold room who can monitor the oxygen supply and maintain a log. So that is a new initiative we have taken up for this. We have an upcoming project in upcoming NABH audits on 5th, 6th and 7th.
Do you have any feedback mechanism that yes, you are constantly on that 68 is not going back?
Sir, we are going through patient safety rounds. So monthly patient safety rounds, we are presenting it in the patient safety committee. So there is an active surveillance mechanism involved, so that we don't drop further from that 68%. So that is our base now, and we have to only improve further.
Thank you.
Thank you.
Next we have
So good evening all, I'm Dr. Manju, I'm the Quality Manager at Baptist Hospital, and I'm going to take you through a transformative journey of our pain points, that is our incidents to improvements. Next. So I would like to draw your attention to this report by the Institute of Medicine, which said, "To err is human." According to this report, 44,000 to 98,000 deaths per year were due to medical errors alone, and out of that 7,000 were due to medication errors. And when we looked at dispensing errors, that was 21% of the total medication errors. To set the context, we have 5 pharmacies at Baptist with 34 pharmacists on roll. And what was the need for this project? We suddenly saw a rise in our dispensing errors from 12 in 2022 to 22 in the first quarter of 2023. So at Baptist, we have a robust system of incident analysis. We have regular meetings with the stakeholders. We do a detailed RCA by going to the site and trying to identify the root cause analysis and a phase-wise analysis and come to the targeted interventions. So this is the phase-wise analysis which we have done based on the causes that we have identified during the errors. And for our interventions, we've categorized it under these 4 headings: the technological interventions, the process optimization, training and education, governance and policy development. So we used to have a manual system of prescriptions. This is a homegrown software where our IT team developed the electronic hospital record, wherein if our doctors prescribe with the electronic hospital record, it is automated for the billing clerk. By this, what we achieved was we were able to remove our pharmacists from non-value added jobs, and they could focus on dispensing, and the billing clerks would do the cash collection and the billing. We also instituted a change wherein the racks were numbered, and those numbers would reflect on our bills, and it would also mention whether it is a sound-alike medicine or a look-alike and a high-risk medicine. So what we achieved was the pharmacist, prior to going to the rack, are alerted whether it is a sound-alike medicine, and we were able to improve the TAT also. In our process optimization, to minimize 2 identifier errors, earlier on our indent slips only had the names of the patient and the order number. So we modified that format to include the hospital ID so that there was a double check of the 2 identifiers prior to issuing the medicines. Since the porters were delivering the medicines at the different wards, we had challenges because of attrition of our porters. So what we did is we brought in visual cues in terms of color coding of the baskets so that the porters could easily identify to which area they need to deliver it. Also, we brought in a register wherein the porter who's taking the medicine marks his name and takes it to the respective area and gets a countersign by the nurse, thereby increasing accountability and responsibility. We also have a system wherein there is a proactive look-alike, sound-alike medicines identification by our pharmacists, which is done on a quarterly basis as and when new brands are introduced. So all the team leaders of the respective pharmacies identify the LASA drugs, thereby minimizing the chances of errors with the LASA drugs. And in our return medication handling, what we did was, before the porters had a right to just keep it in any racks, but here we gave the responsibility to the team leaders of the respective pharmacies to ensure that it is accurately placed in the respective racks. We believe that a continuous culture of learning is very important to minimize errors. So we have scheduled training for our pharmacists, wherein trainings from incidents or the learnings from the incidents are imparted to our pharmacists, billing clerks and porters. We believe that we shouldn't make the same mistakes again. We can make new mistakes, but we should not try to make the same mistakes. So keeping that in mind, we have conducted trainings, and this happens in a scheduled basis. There is also orientation training which happens to our billing clerks on the new billing module, and the porters are oriented to the facility, and also they are sensitized on the new interventions that we've brought about. In our governance and policy, we came up with a policy on cut strip medications, wherein we stopped taking back cut strips below the value of 100 and temperature sensitive medicines. And we also introduced 2 new pharmacies, a pharmacy for our OT and another pharmacy which was dedicated for our surgical OPD and opthal OPD. So with all these interventions, we were successfully able to reduce our incidents from 22 in the first quarter to 8 in the second quarter and 5 in the third quarter. Thereby, overall, we have brought about a reduction of 77% from the first quarter to the last quarter. And also, this has resulted in 17 kaizens, which are small changes for the good. So we believe that continuous quality improvement is a journey, and with all these interventions that we've put in, we are trying to get better and better every day. Thank you.
Good presentation. Just one question. Your digital prescription, is it 100%?
We are currently around 88 to 90%.
That's good.
The medicines, if they enter the hospital ID, the medicines will reflect there.
A lot of emphasis was given on training, so how do we majorly post-training effect?
We have a pre-test and post-test and all that which is put in place, but again, looking at the numbers that have brought, I mean, we've succeeded in bringing down the numbers. I think with that, it's implying.
Thank you.
Next up, we have Ms. Nirmala.
Namaste sir, Namaste one and all. My name is Nirmala, I am from Apollo DRDO. My presentation is on clinical handoff. Effective communication facilitates the transfer and acceptance of patient care responsibility during nursing clinical handoff. The SBA structured handoff tool was introduced by the World Health Organization in the year 2000 to improve effective communication. Clinical handoff involves the real-time transfer of the patient-specific information between caregivers to team to ensure continuity and patient safety. The information must be clear, accurate, complete, up-to-date, and it must be clearly understood by the recipient. The ineffective handoffs can result in clinical gaps in patient care, compromising safety. These lapses may lead to medication delays, errors, delayed reporting and management of critical values, postponed orders execution, procedures delays, and even procedure cancellation, etc. Objectives include to be complaint with IPSC Goal 2, effective communication, identify barriers in the nursing handoff process, discuss with the standard of effective communication, to identify the components of effective handoffs, developing a robust process is essential to safeguard against the potential errors. Ensure the effectiveness and accuracy of clinical handoff is crucial to ensure the continuity and safety of patient care. Goals include prevent errors, decrease incidents on IPSC2, length of stay, handoff time, voice of customer complaints to increase the customer satisfaction levels. Rationalize, it is inadequate in handoff that safety often fails. A structured approach must be failed while handing over the patient information, as this process is crucial ensuring the patient safety. Transition of a critical information ensures continuity of care and treatment. Failures to achieve effective handovers is a major source of preventable patient harm. When does the clinical handoff occurs between nursing staff? Nursing staff engage in written handovers of patient care during specific occasions. Shift changes, transfer the patient to wards to ICUs, vice versa, emergency to wards, ICUs, OTs, and diagnostic centers. When the nurse has to relieve the patient's care area briefly for a valid reason. Methodology study includes all the nursing handoffs done through the SBAR tool, ticket to write and write to ticket. Exclusion criteria doctor handoffs. Sample size we have taken only 60 files. Audit was done in all the wards and critical areas. Duration of this study is 1 month. Sample colors based on the random purposive sample techniques. 10 members of team was formed including the team leaders, ward nurses, supervisors, educators and NS. The custodian reviewed the handover forms for errors and completeness. The information gathered used to improve the process. Staff knowledge awareness we have given. Pre-test posters was conducted for all the staffs. Training on hand toolkits we have given. Focused training on IPSC. This is a toolkit we have implemented for doing the audit. This is a pre-project audit. Ward-wise we have achieved the score. Total complaints were 79, non-complaints was 21. We are able to address through the staff training. Audit observations were time pressures, length of stay, interruption during the handoffs, language barriers, punching staff at the last moment and taking handoffs in a hurry, increase the length of stay of the patients, decrease the patient satisfaction levels. This is the SBAR tool we have implemented. SBAR stands situation, background, assessment and recommendation. It includes complete patient information with acknowledgement of staff. Ticket to write and return to ticket. This is the patients where from IP to OP when we are shifting, this is the handoff we are using. This is the recommendation of this study. Limited interruption during the handoffs, encourage the bedside handoffs. Handoff register to be maintained. Handoff checklist to be maintained. Consultant instruction and information. SBAR forms also we have implemented. Reporting to the 10 minutes prior to their duty timings. Debriefing by in-charge nurses or team leaders. Action taken for this study. Trained all the staff nurses. Appreciation the staff handoffs on time. Random files were audited by the custodian on daily basis on handoff. Daily file check by the charge nurse or team leader. Check by the on-duty supervisors for new admissions, pre or post-op and med calls, etc. This is a knowledge assessment we have done for the staff. This is a post-project we have done ward-wise audit and we are able to achieve 97.1 and non-compliance were 2.0. This is the conclusion of my study. Patient safety is the priority. In patient care and communication errors are the most common causes of adverse events during patient care. This is the reference. Thank you. Actually, we have taken this study. After that, we have lot of med calls was increased. Code blues, we had a 3 months 0 code blues, and we have submitted the project, real project, and submitted to the NABH also said. And it is we have implemented many forms. It was the SBAR, ISBAR, CIA forms, ticket to write, return to ticket. So actually, it is internal and external customers both are happy with this feedback. Thank you.
What was the difference between the ones who did well and the ones who, the departments which really did well, and the departments which were not as good? So, what was the critical difference? What was the critical success which drove the project?
Yeah, actually, it is during handoff if doctor comes for rounds. They are writing some investigation. They are not giving the handout to the next person. They missed out many times because they don't have proper handoffs. And this even not only investigations, even medications. We all know that practically how it is happening in the wards and during consultant rounds. Many times, in spite of telling, they writes in a progress sheet medicines. It is not in a drug chart.
How many handover did we increase websites?
Sorry?
How many handover were taken at the website? Did we measure that? Before that, how many handover was taken nearby website? The postal process.
Yes, sir. We
highlighted that equipment inside. So how much was the improvement in the website?
Yes, the before project we identified most of it is like it is 98% people are taking the handovers in the nurse stations. So we strengthened our team leaders, supervisors to monitor under, and if we have kept also, it is within 45 minutes to 1 hour they have to leave the patient area after handover. And we have cross-checked with the punching, what time they punched in, what time they punched out, with the help of HR. Thank you, sir.
Next up, Ms. Gauri Jagdish.
Good evening, respectful moderators and present, one and all present here. Myself, Gauri, nursing educator from Fortis Hospital, Banarkata Road. I am here for the paper presentation under the category of learnings from incidents and errors. The topic of the presentation is the prospective study for prevention, early identification and management of neonatal hypoglycemia. The neonatal hypoglycemia is a low blood glucose concentration in the first few days of life. It poses a significant challenge in the early neonatal period and can lead to complications if not promptly recognized and treated. When we look into the risk factors for the neonatal hypoglycemia, the fetal factors like intrauterine growth retardation, premature or post-mature deliveries, and maternal factors like preeclampsia, gestational diabetes mellitus mothers, and congenital syndromes, meconium aspiration syndrome, erythroblastosis fetalis, and all these are the risk factors for the neonatal hypoglycemia. When we look into the background of the study, the incidences of neonatal hypoglycemia is reported as part of our nursing practice audit at our Fortis Hospital, Banarkata Road. Actually, in the month of March 22, we found there were 12 incidents of hypoglycemia in the neonates. Even retrospectively, when we go back and checked in the month of January 22, it was 11, and in the month of February 22, it was 12. So out of 112 deliveries in those 3 months, it was the reported incidence was 35, that is 31.25%. Looking at this alarming incidence, we just brainstorming session were taken by our neonatologists, obstetricians, lactation consultants, and the nursing team also involved, and we have come out with a revised algorithm which was taken from the American Academy of Pediatrics, and then after applying this algorithm, we developed a new algorithm. Then the incidence has drastically come down. That is what I am going to explain about this study. So the problem statement, it is to do a prospective study for prevention, early identification, management of neonatal hypoglycemia at Fortis Hospital, Banarkata Road, Bengaluru. The aim of the study is for the early identification, reduction in neonatal hypoglycemia, with the objective of to implement the measures to reduce neonatal hypoglycemic events in newborns nursed in labor, delivery and recovery postpartum unit, and also to evaluate the effectiveness of measures implemented in reducing the neonatal hypoglycemia. Our data collection, actually we do a nursing practice audit to capture so many nursing quality parameters. In that way, we identified the neonatal hypoglycemic events also. All the newborns, whoever is born in the LDRP with hypoglycemia, we have taken as a sample. And the duration of study, we took it from January 22 to February 23. And we went through the purposive sampling technique with a sample size of 45. And when we look this, actually this slide represents the incidence of neonatal hypoglycemia from January 22 to February 23. When you look on the top, January 22, February 22 and March 22, we can look, there is 11, 12, 12 with a percentage of 30.5, 33.3 and 30%. Whereas after implementing the new algorithm, we could find drastically the incidence was reduced. And also in the August 1, just we can find August 22, we found one incidence, and in the month of November 22, we found one incidence. So this is the trend chart. So this also, this just represents us how drastically the incidence was reduced from the January 22 and the February 23. Apart from that, and also we went still more further in category wise also we classified. Because to specify that, like below 50 milligram, how many babies were with neonatal hypoglycemia, and also below 45 milligram, how many babies were with the neonatal hypoglycemia. When we looked into that, this is also shows how many babies we had. So totally we had 45. In the 23 babies we had below 45 to 50, and 22 babies we had less than 45 milligram per DL. And so what is our learning points from here? What we understood is, we had a categorization that already I mentioned in the previous slide. The percentage shows here 51.11% with less than 50 milligram per DL, and 22, that is 48.88%. Along with that, we could also identify there is a 43% of the neonatal hypoglycemic babies had gestational diabetes mellitus is the highest risk factor. And also the error what we identified is we did not have any standardized protocol to manage this neonatal hypoglycemia in our organization. That is why we just, with reference, we just moved into the new algorithm we developed. So also we applied as a quality improvement process. We stick on the PDSA cycle. Along with that, we can find here, this is the reference from American Academy of Pediatrics with the categorization of the reducing the incidence of neonatal hypoglycemia, along with the glucose metabolism, sugar wheel nomogram for postnatal glucose homeostasis. With both these reference, B4Ds made this new algorithm with all our team members. Simplified algorithm, standardized algorithm, it was created, and we just started adopting this. This made our incidence come down to the, what I showed in the previous slide, the incidences come down. And also, this is what the thing, and this is what the results and the overall improvement, which I would like to represent here once again. So the conclusion, when we come to the conclusion, same thing only like what I presented in the starting slide. We had the total incidence 31.25, and drastically it has come down, and in the August 22, 2.04, and November 22 it was 1.49. And also when we looked into the why it has occurred, that August month, that is because the baby has got some endocrinology issues. That also treated and baby has discharged. And the November 22 baby had gestational diabetes mellitus. So that is also we did the analysis. So overall, our recommendation is when the project actually, we never had any additional cost involved in this, and the reduction in the baby's stay and mother's stay was reduced, and it reduces the chances of infection and saving the manpower utilization. And overall outcome, drastic decrease in the incidence of neonatal hypoglycemia, and we recommend to use this new algorithm. And also, so that is why it comes under the category of the, as nurses, we learned these incidences made us to learn. All these alarming incidents made us to learn that something is going wrong. Then we moved and referred with all the team members, came out with the new algorithm, which made us to have, till today, we have got a zero incidence of neonatal hypoglycemia. These sustainabilities because of the continuing nursing practice audit, training, supervising, and guiding the staffs regarding the adaptation of algorithm, and patient and family education on signs and symptoms of neonatal hypoglycemia, and importance of early initiation of breastfeeding and continuing the demand feeding. So this is what, this is the reference. So this is what the project did. Thank you for the opportunity. Thank you, thanks.
So all the presenters have collected certificates. Just write your name. Yes.
Thank you, sir.
Let's link it again. Session starts at 12. You also know what to do. ठीक है? कल तो भी होना है ये रहने सर्टिफिकेट सब दे दिए एक 1% है ब्लड क्या नाम था उसका मंजू चा she had presented she left early उसको बोला सब बाकी सबको दे दिया हमने तुम्हें तुम्हारा नाम लिख लो उसी को मंजू चा को she left early he had to take the certificate yes Patient number you can keep it there. And tomorrow's script, who's preparing? Tomorrow's script. She prepared. She wanted to morning presentation.
Feedback team arrives there. They just check out the blue code where has been detected and we stakeholders. We come like as a team of the hospital and just explain everything to the patient. Like this whole this lecture and we go around.
Keep it.
Take actual
What is that?
immediate this
Jaya, call me after you finish. Phone panna.
Thank you. So many things like trainings, education, social training. So we are always try to cover up all the patients on different floors assigned areas, and we do regular meetings, frequent meetings. All the person will come from housekeeping, from nursing, from Adam. So we take and identify
does what does. Wherever nobody goes, we go and we achieve the patient safety. It's from last 3 months, like study we were doing. It's like if you listen to the patient, half the problems are really stupid. Then and there. Just to adding some point, we started with your quality education. Every hospital has a feedback system. Every hospital works on the discharge feedback, and we analyze and then we come up to the result. But for what we analyze is it's too late. When patient is gone, he's given you the feedback, which could be resolved at when the patient is inside. So our focus is when we collect live feedback, our focus is the patient go happy. So by this, by live feedback, we are brought down many of the problems which patients write on the discharge and we say, oh my God, it could be resolved within seconds, have been resolved within minutes, and then the patient is there. And that is why there is a drop in dissatisfaction, and we are nowadays receiving good discharge feedback comparative to the last because of the night. Yeah, because the focus is we are very happy when we get a larger number of complaints during night feedback, because then that is why we know yes the discharge satisfaction will go on. So it is vice it is inverted proportional. When we get more live feedbacks negative, we know the discharge feedback will be positive. Thank you so much. We are very much getting that during the live feedback, the maximum number of complaints about not receiving the water bills, very little complaints at night time. So we analyzed those many complaints and we made a solution that we analyzed the patients and we made a solution that during the night time we have one more SMP guy who will rotate and check the jugs by themselves and get it reviewed before patient asks. And that is being appreciated by patients so much that our feedback for FMP has gone really well in that positive. Just a small example. So we work like as a team to achieve the optimum result. Thank you. Have a nice day. let me take through how to build robust workforce and patient safety strategies, innovations, and collaborations. Now, the logo and the motto of Jupiter Hospital is patient first. Keeping that in mind, we ensure safety and satisfaction along with strong workforce and utilization of evidence-based innovative strategies and technologies. So, if you see the picture, the nurse collaborate with all the departments in the hospital. So, she being in the front line of providing direct patient care, she becomes vulnerable to numerous stressors while balancing the needs and demands of the modern clients. So there was a need to strengthen and enhance their knowledge, skill, attitude, critical thinking, and making them competent to provide quality care to patients. So the methodology we adopted is the Kaizen process for continuous improvement. That is change for the better or continuous improvement. Illustrate us what are the problems, causes, solutions, and initiatives, and the type the mirror shows the patient safety, focuses on patient safety and satisfaction. So the problems and causes were compromised patient care because of the turnover of the nurses, there was communication breakdown because of language proficiency, transition difficulties like I know we all are hearing this COVID batch, because they had a lack of instability, lack of confidence, and there was delay in emergency response because there was no critical thinking. Inadequate competency for senior role, hence juniors had to take up the role of the seniors, and the incidences and errors were high because there was non-compliance with set standards. And to talk about solutions and initiatives, what we did first is we strengthened the OPE batch, that is the novice nurses, nursing and induction and orientation was given, and we also the existing nurses. We had a continuous professional development for them. Like as you see, we had wound care nurses, critical care nursing, nurses of adult and pediatric, IDCC and hemovigilance nurse, medication nurse, body boosters, palliative care team, ortho clinical nurse specialist, onco nurse, pain management nurse, and IV nurse. And what we did is fine-tuning the skills. So we've used dissemination-based learning and also assimilation instructors. So we used this for all the training programs, and we focused not only the novice nurses, the existing nurses, revise and revise. That is, every quarterly we take back to basics, so we have a refresher course for them. Wellness program where the nurses, physical, social, mental, and the financial aspects were also considered, and there was a holistic approach sessions taken. Learning from incidences, we had a group code where sensitization of incidents is done. Patient engagement, that is feedback, and community involvement where nurses went to the community and provided various sessions to the community. So how we started our journey is we had a roadmap to the initiatives. We had a brainstorming session, and we follow bottom to top approach, and we charted out our vision and learning planner based on the feedbacks and the training need analysis. So we follow shared nursing governance model where we have practice council, education council, and